had done lectures on different topics in the past, and we are going to be doing lectures on advanced cardiac imaging this session. Thank you for joining us. Please, as a reminder, keep your microphones muted, but please feel free to post any questions or comments you have in the chat box. Along with me, I have my FIT co-chairs, Deepak and Vikram with me. They're going to be moderating the chat box, and we'll post your questions to the speaker at the end. So without further delay, I'd like to go ahead and introduce our first speaker, Dr. Matthias Friedrich. Dr. Friedrich earned his MD at Friedrich Alexander University in Germany. He completed his training as an internist and cardiologist at Humboldt University in Berlin. And since then, he has been appointed with the University of Calgary and currently at Montreal Heart Institute. He joined the departments of medicine and diagnostic radiology as a full professor, and is also the chief of cardiovascular imaging and scientific director of the cardiovascular signature program at the McGill University Health Center. He also has an appointment with the Department of Medicine at the Heidelberg University in Germany. He's a staff cardiologist at the Royal Victoria Hospital and an active researcher with a strong interest in novel imaging techniques. For those of you who logged in a little earlier, you should have kind of tuned into our conversation about his research interests. But he has focused the research activities of his team of 20+ researchers on cardiac MRI of myocardial injury, acute ischemic, and inflammatory conditions. His scientific interest is focused on new approaches for diagnosing cardiovascular diseases using CMR, with a special interest in novel diagnostic approaches to visualize heart disease. Currently, his team is working on simultaneous multi-parametric acquisition and reconstruction techniques, oxygenation-sensitive CMR, and the diagnostic utility of breathing maneuvers in diagnosing coronary vascular diseases. He authored or co-authored more than 200 peer-reviewed publications with more than 20,000 citations. He was the founding president of the Canadian Society of Cardiovascular Magnetic Resonance and the president of the SCMR. He's also the scientific director of the Cardiovascular Signature Program, a long-term initiative for developing AI-informed strategies for personalized cardiovascular health management. For those of you actively involved in cardiac MRI, I'm sure you recognize Dr. Friedrich. He's been on numerous position statements, and a lot of his work was involving myocarditis and mapping and so on. So I would like to thank Dr. Friedrich for taking time out of his busy schedule and making himself available for us. So I will pass it on to Dr. Friedrich.
Thank you very much for the kind introduction, and welcome everybody. And I also appreciate that you take the time on the weekend to get yourself a little bit more knowledge, and I hope I can contribute to that. CMR is, I think, a very important, and from my point of view, the most important imaging modality when it comes to visualizing inflammation, because there are several criteria associated with inflammation, and it's quite difficult for any of the other imaging modalities to visualize even one, let alone all of them. So I will go through both myocarditis and pericarditis. Before I do so, I want to disclose that I'm involved in software development, and I have research agreements with several companies. Not I myself, but my institution, and we receive research funding from also several public and private founders. Pericarditis, especially these days when we deal with pericarditis often induced by COVID, is to me sometimes underappreciated disease, because typically in old days we relied on pericardial rubs, the pleuritic chest pain, and then pericardial effusion, but none of them is really that sensitive, and sometimes pericarditis can have, let's say, a little bit of a challenging clinical presentation. So I owe some of these slides. I want to thank Michael Chetrit from my team for these slides that I could use and modified them a little bit. And this is from his paper published in JACC Imaging 2 years ago, or 2.5 years ago. And here you see what MRI can offer in the various stages or form of pericarditis. So we have the acute pericarditis. In this acute stage, it is about, in any acute inflammation, we have an accumulation of water. This could be swelling if it's tissue, or effusion if it's serous space. And DHE stands for delayed hyperenhancement, which is a technique, a contrast enhanced technique, typically referred to as LGE, or late gadolinium enhancement, which displays the accumulation of a contrast agent. Typically it's gadolinium. Gadolinium is an extravascular agent that goes anywhere where there is space. And in inflammation, you have an increase of the extracellular space. So a contrast agent goes there, stays there for longer than it should be. So if you take basically your photo, your MR image at a time where from normal tissue, the gadolinium is already washed out, you have this remaining contrast agent in areas with an increased interstitial space, or other spaces where the contrast agent can get to. And so these are two markers for the inflammation. One is the edema or the effusion that can be visualized by T2weighted imaging or T2 mapping, because the water in T2 leads to a lot of protons that are bound to water. Protons bound to water have different magnetic properties, and their T2 relaxation time is very long. So we can visualize that with a high signal intensity. And here you can see that there is some effusion around the heart. So this is a short axis view. And here, this is the left ventricular chamber, right ventricular chamber. You see the bright ring around it. In a T2weighted imaging, that means there's water. And around a normal heart, here you can see this on this in this panel here, there is the water around the heart is really not detectable because it's just very, very thin. And when you have water that is consistent with pericardial effusion, so that's one thing, the acute quote unquote edema. And you can have that, of course, in the myocardium when you have myocarditis. And then there's the so-called late enhancement or delayed hyperenhancement, a term that is not that much used anymore. That is the contrast agent accumulation that you can see here in this image, a bright ring that encircles the entire heart. And that is important. So these are two markers, both reflect different aspects of the inflammation. Here it's the edema, and here it's the associated increased blood flow into that area and then increased interstitial space that could be edema, but also typically is a tissue that is not only inflamed, but also shows already signs of necrosis or irreversible injury, where you have a deterioration of the cell membranes, and then this contrast agent just stays there practically forever. Forever in that context means for hours at least. So that's already the most important takeaway: edema, late enhancement. So if you have recurrent inflammation, it's basically the same thing, although in some chronic stages, you may or may not have effusion or edema. And so that's why the T2 criteria could be negative. And if it's burned out, then nothing may be positive anymore. And then there are other signs. I'll come back to that in a minute. So pericarditis could have a constrictive impact on the heart, which means it may not allow the heart then to expand completely. And this is important because this reduces cardiac output or stroke volume, and then patients respond to that by higher heart rate. But if that is not sufficient, and even if it's sufficient at rest, it may be not sufficient when they are physically active. So this leads to shortness of breath, and this cannot be reliably identified by other modalities, because this is the ejection fraction looks normal. You may not see effusion. And the symptoms may, of course, also be non-specific, because it's not necessarily the pleuritic chest pain. It's more really the shortness of breath and non-specific tightness. So with MR, what you can see using the same technology that you see, you can see the effusion as you can as seen here. In the recurrent or chronic stages, it's less frequent. However, we're seeing, especially in these days with COVID, post-COVID, we see quite a lot of patients that who have small pockets of pericardial effusion, which means there had been pericarditis with some fibrous reorganization, leaving some pockets. And these pockets are not necessarily always benign, because they can have kind of, they can lead to a fusion of the pericardium and the myocardium, and then to tethering that may induce arrhythmia, that may induce some non-specific chest pain. So that is also very helpful. And then, of course, in burned out myocarditis, as in any inflammation, whether in the coronaries or elsewhere, chronic inflammation may lead to calcification. And this is what you can also, against public opinion, also see quite well in MRI. If you just look at all the images and the pericardium is always dark in that area, then that that actually signifies or can signify a pericardial calcification. So what is the role now of cardiac MR? Taking this together, first is defining pericardial anatomy, then assess whether there is active inflammation, then try to determine is it acute or chronic, then look at the hemodynamic relevance. Here we're mostly talking about evidence for constriction, and eventually then inform therapy by that. So let's have a look at a few images. So the standard black blood spin echo sequences, often done in an axial mode, are already quite helpful in many cases. Of course, here you have to see that, and you can see the subcutaneous fat is bright. So here around the right coronary artery, you see also it's bright. So you can assume that most of what you're seeing here is fat. So you have to be aware that this is of course, using this technique alone, you cannot do that. But if you have a double line where you have fat and then something else, then you just need another sequence then to verify that. And here is a typical example of a pericarditis in a rather early state. You do not have extensive pericardial effusion, but the T2weighted imaging clearly shows this telltale line around the entire heart. And T2weighted imaging is not the easiest because there are, let's say, errors that can be made during the imaging. The T2weighted imaging has a relatively low signal to noise. It's sensitive to arrhythmia, so it has to be in hands of people who are used to image the heart with T2weighted sequences. Pericardial late enhancement is also something that may pose some challenges, and also from the same review, I already showed you this case here, and this was a study that compared it with biopsy and could show quite convincingly that the tissue in acute inflammation with necrosis and granulated tissue abnormalities with new vessels moving in is visualized, as well as let's say the thickening that's associated with it. Whereas in normal myocarditis, they have a very thin layer of fibrosis, which is typically not detected. And this can also be the case in very chronic stages. So here is another example. So as you can see in this 4-chamber view, the heart in terms of the motion looks quite normal. The ejection fraction would be normal, but very often what you see in these cases that if you look at the volumes actually are on the low end. And very often, even though the ejection fraction may still be completely normal or even high, your cardiac index is on the low side. And then you have patients who are obese, who the cardiac index then, because of the body surface area, drops further. So this is an important additional quantitative marker, the stroke volume index and cardiac index. So here are some other examples of the late enhancement associated with pericarditis, it's typically basically surrounding the entire heart, and this is what makes it different from fat that does not have this appearance, but only has certain areas that are typically around the left ventricle where you have some fatty accumulation. And then our sequences also allow us to then just use that so-called fat sat, basically switch off the fat signal and then verify it. And we do that in clinical scenarios quite often. So the diagnostic accuracy for pericarditis is when you do that T2 and just T2 and LGE, you have a sensitivity of 73 and a specificity of close to 99%, at least according to this study. Now, the sensitivity of 73% doesn't sound like a lot, but if you look at the clinical criteria, so it is actually pretty good, because if you look at the clinical criteria, they are often not necessarily positive. Only half of them have a rub that you could auscultate. Not all of them have ECG changes, and even less may have pericardial effusion, especially in the rather early stages. And sometimes pericardial effusion can be quite local and basal and lateral. So this is not a great place for echocardiography to look to. So the diagnostic impact of cardiac MR is actually quite huge. So when you look at the different stages, and I would like to refer you to that paper to have a closer look, various stages have various appearances in echo, but also in the MRI, in their MRI appearance. And this largely reflects what I said before. So maybe you have a look here if you're more interested in that. So let me visually summarize that a little bit. Pericarditis leads to an inflammatory abnormality of the pericardial space with respect to effusion. Leads to thickening, but not necessarily a dramatic thickening of the pericardium, to a change of the interstitial space, which leads to an increased contrast uptake and then to late gadolinium enhancement. And the effusion can be visualized by T2weighted imaging. So it's basically similar to myocarditis, which I will talk about now in a second. What we are doing in clinical routine is you can quantify the enhancement, although it's not necessarily of clinical relevance to quantify that. That's more to quantify late enhancement is increasingly used in hypertrophic cardiomyopathy or in ischemic injury, but not so much in pericarditis, but you can do that. What we're doing is looking at myocardial involvement, basically also looking at T2 and by T1. Here is a native T1 map. In that case, we can also see the abnormalities in the pericardium, but we cannot use the normal values that we use for the heart for the pericardium, of course. So this is mostly for looking at myocardial involvement. So that brings me to myocarditis. Myocarditis, and this is the same for pretty much any of the viral myocarditis pathology. Myocarditis in general, I just want to be very clear, myocarditis in general refers to myocardial inflammation. That's what the term says. And myocardial inflammation could be the response to anything, to viruses, but also to allergic components or components that trigger allergies. Could be toxic, could be radiation, could be an ischemic injury, could be catecholamine overflow. So there are a lot of reasons for tissue to respond with an inflammation, which is per se non-specific. So inflammation itself is not viral necessarily. of course, when we talk about myocarditis in clinical routine, somehow most people then automatically basically are on the track of viral myocarditis. But we probably have at least as many other etiologies for clinically impressive cases with myocarditis. For example, Takotsubo, for example, sarcoid disease, acute stages of Fabry's disease. So there are others. So I just wanted to point that out. Myocardial inflammation itself is not specific. So but we're talking about viral myocarditis. You have an initial exposure to the viral agent and then to the systemic inflammatory response. And both of them can lead to acute edema. And then that could involve the pericardium and the myocardium. And this could also lead to necrosis and then scar. The scar may stay even after recovery. And actually, I want to already say that here, it always stays. And yes, there are reports, lots of reports that late gadolinium enhancement, quote unquote, goes away. It doesn't actually go away, it just shrinks. And we know scar shrinking reduces the size by about 70%. So if right off the bat, the late gadolinium enhancement initially with respect to necrosis then shrinks by 70%. If it was initially not very big in the first place, then we may not see it in MR. And then there comes edema. Edema leads to some increased signal intensity of late enhancement. So that's why it sometimes seems to disappear, but the scars, of course, stay. So whatever you initially see as late enhancement in a patient with myocarditis, there will be some scar left. But if it's just edema, and these cases also exist, and I have an example for that later, then the recovery may be without scars or without discernible scars. And then there are sometimes persisting issues, persisting pericardial infusion or pericarditis, then persisting edema, which is especially important in COVID. And of course, when we talk about myocarditis these days, we have to mention COVID. The difference between COVID and other viruses that may affect the heart is that COVID enters the system through the AC angiotensin converting enzyme 2 receptor. And the ACE2 receptor has a specific role or roles. One is actually moderating an inflammatory response and establishing the integrity or maintaining the integrity of the vessel wall. So if the ACE2 receptor is knocked out by viruses, as it is the case in COVID, then this moderation effect on the inflammation goes away, so inflammation may be more severe. And the stabilizing effect on vascular membranes goes away, so there may be more edema. And this happens in every acute inflammation, but in COVID, it may be that the damage on the ACE2 receptors may prolong that. So there's edema for longer, myocardial edema, pockets of pericardial effusion, and in the lungs, similar. So that's why people often take a long time to recover. And in some cases, we even probably have an autoimmune response so that the body then itself knocks out the ACE2 receptors, mistakenly seeing them as the invaders. And this is probably the reason for the cases of long COVID we're seeing. So that's the problem with COVID-19. So, but back to myocarditis, as I mentioned before, cardiac MR is the most versatile imaging modality, but in this case, the most important really focus is here the tissue characterization. And I already mentioned the two basically classical approaches: edema-sensitive imaging by T2weighted imaging here in the case of a reperfused MI in the LAD territory. And this is the same patient actually, and this is just the computer-aided automatic evaluation. And here you see the increased signal intensity that reflects the scar. So that's late gadolinium enhancement imaging. So edema and the irreversible injury both can be visualized. But to differentiate that from inflammation from other causes has to mainly work by looking at the regional distribution and the clinical history. So here we have edema when compared to healthy subjects in coronary artery disease. We have the edema associated with the territory of the ischemic injury, of course, whereas in acute myocarditis, it is more diffuse. However, a lot of the myocarditis cases, the more severe in the younger people, actually happen also inferolateral, at least more often than elsewhere. And this is interesting. One could speculate why that is. Is it because when you lie on your back because you're feeling sick that you have more pericardial effusion in this region, and then you have invasion maybe from the pericardial space? Who knows? So this is still up for science to clarify that. The regional distribution is also important for the late gadolinium enhancement, because in ischemic injury, as in this case with a triple vessel disease, the ischemic injury always includes the subendocardial space. There are sometimes cases where it seems it doesn't, but that's just then in areas where the trabeculation layer is perfused by a neighboring coronary artery. So there is no way that an ischemic injury in a coronary artery stenosis or blockage does not include the subendocardial, because that's always the most challenged region. You may have cases where second degree vessels are involved, and then an embolic injury may look a little bit different. It's more vertical through the wall. But in all the basically garden variety of coronary artery disease related ischemic injuries, you have subendocardial involvement. This is of course not the case in myocarditis, which almost never involves the subendocardial layer. It's more, and that also is an argument that the entry may be in many cases through the pericardium. You often have a subepicardial or an intramural, more patchy involvement, not the thinner layers. But you may have myocarditis, as I said before, without late enhancement. Here's such an example. So this is a patient with normal LV function. This is what we used in the early days as a marker for inflammation, the so-called early enhancement. So that is a marker for the uptake, the early uptake of gadolinium. It's actually still a nice marker, although we do not have lots of studies showing, they just have not been performed looking at the prognostic impact and the impact on outcome. So that's why these days it's mostly the T2weighted imaging and the late gadolinium enhancement that had been used. And since a few years, mapping has been added here. But in this case, you have increased uptake of the early enhance of the contrast, which reflects the hyperemia associated with inflammation, and you have edema, but you do not have irreversible injury. So this is a milder inflammation that that does not necessarily come with any late enhancement at all. So it's important that late enhancement alone does not allow you to rule out acute myocarditis. And it also, of course, does not allow you to say whether it's acute or chronic, because if there is injury and it's 5 years old and the scar is big enough that you can see it, it will be positive, whether or not there's an active inflammation associated with that. So edema is different. Edema is something reflecting an active or acute inflammation. Late enhancement just talks about the injury caused by the inflammation, be it acute or old or chronic. Some people may say, okay, why not do an echo? And if the echo is normal, then if there's no dysfunction, then it's probably okay. And then we move on. But here's a typical case that shows that this is a kind of a dangerous path. So this is a young patient who comes with typical chest pain, ST elevation, and a positive troponin. Echo said everything's normal. And if you look at the long axis views here, 2-chamber, 3-chamber, and here the short axis view, function overall seems to be okay. However, if you take a close look here in the three-chamber view, the inferolateral wall here is not moving in that nicely. But you could say, okay, overall normal ejection fraction, so that's okay. So you could argue maybe this is not severe inflammation and we could send that patient home anyways, because whatever it is, it cannot be that bad. But if you look at the tissue, it's pretty brutal in this case that you have a lot of areas with necrosis. So this is kind of extensive myocardial necrosis in a patient with a almost completely normal LV function. Why is that? Because in younger people, even if you knock out a lot of cells, the remaining cells are able to compensate for that. So they will contract well enough that overall the contraction and the ejection fraction may be preserved. Not in all of them, but in fact, in most of the studies, more than half of the people have a completely normal LV function. So point here is a normal LV function does not allow to rule out even severe myocarditis. So I talked mostly about the classical criteria. So that was the T2 for edema and the late enhancement. And that's also what I talked about before in the pericarditis. And then the early gadolinium enhancement reflecting hyperemia and also early capillary leakage. And this, the so-called classic Lake Louise criteria, you had to have 2 of these 3, which means if you think about it, you would always have to have one marker that is associated with acute inflammation, at least. So late gadolinium enhancement alone wouldn't do it. You would have to have either edema or hyperemia, or you would have had to have edema plus hyperemia in cases without late gadolinium. So this worked quite well in the diagnostic accuracy of the criteria. Even fairly recent studies have shown that the diagnostic accuracy is good, is definitely way better than biopsy. And which shockingly, just recently, we had a workshop of the ACC just a few days ago, and meta-analysis was rediscussed. Even immunohistology has a sensitivity of about 50%. So that's not a good way to rule in or rule out myocarditis in a patient. Plus that it's invasive and expensive. So if 2 out of these 3 criteria are positive, you have an accuracy of at least 75 or 80%, which is pretty good. But of course, we have now mapping, and I will not take the time to go too deep into the mapping. So mapping is basically a way to get around looking just at signal intensities, but directly estimate or measure the magnetic properties. And the important properties are the time it takes for the system to relax. So the relaxation, as this can be described by T1 or T2. These are the 2 times to have the system. This is the vector of the spins after a high frequency pulse, and the transversal distribution that is in phase while you're beaming in a high frequency pulse and then gets out of phase. Forget about that. That's all the physics behind it. But 2 times the T1 and T2 reflect the magnetic properties of the tissue, and there are normal values for normal myocardium for T1 and T2. However, these normal values are fairly specific for the system you're using, the MRA system that you're using, and they always have to be verified locally. So that's one limitation of mapping. But still, mapping has shown in several studies that it is probably more accurate, even more accurate than the classical markers like early enhancement and such. So that's why we teamed up again a couple of years ago and updated the Lake Louise criteria for cardiac MR and myocardial inflammation. Again, just this is not viral myocarditis, it's myocardial inflammation. So these markers will also be positive in a patient with stress-induced cardiomyopathy, which is of course also inflammation. And they will also be positive around myocardial infarction or in acute reperfused myocardial infarction, which also is inflammation. So the Lake Louise criteria have 2 criteria. One is T2 based, so that's the edema. That could be the old T2 weighted imaging, which still works for many quite well. And that could be the T2 mapping, which I think when ironing out all the current, let's say, problems with standardization and normal values and such, I think is the way to go in the future. And even now, so either one of them reflects one T2-based criterion, and the other one would be the T1-based criterion, which basically reflects the injury. And there we have the classic late gadolinium enhancement, but you could also use a native T1. So because the T1 is positive or increased in edema, but also in necrosis or fibrosis or scar. And then if you use a T1 post-contrast, you can actually calculate the extracellular volume. And this is the third of the T1-based criteria. So what we said in this paper is you should have both. However, and that's very important to keep in mind, if there is a very strong clinical suggestion, so a patient with a typical recent history of upper respiratory tract symptoms and then chest pain, abnormal ECG and everything, then even one of those criteria is enough to confirm that this is very likely myocarditis. The others, pericardial involvement and systolic dysfunction, are just supportive criteria. And one may argue how much they add. I think I certainly consider pericardial involvement a little bit more important than dysfunction, because dysfunction is, I don't want to say atypical, but it's definitely not required for acute myocarditis. So these are the updated Lake Louise criteria. Yeah, you should have one T1 based criterion and one T2 based criterion. Of course, supportive criteria may further support that. And in a patient with very typical strong clinical suggestion, even one of those. And with that, you have a pretty high. And one important aspect here, I want to just point that out again. This allows, and this was on purpose that we put that in there, this allows to basically rule in or rule out a myocarditis by good quality maps alone, which does not require the injection of a contrast agent, which is important in young people. I try to avoid contrast in an injection wherever I can. I think the future of CMR has to be non-contrast, but for now, we still need it in some cases. But if you have a cardiac MR and after the native maps, they both look normal, then there is no need to inject contrast. If they're both abnormal, no need for contrast, because then you have also shown this is consistent with acute myocarditis. Only if one of them is positive and the other isn't, then you have a problem. Then you need another one. So in this case, you would then inject and look for ECV and or late gadolinium enhancement. Okay, so this is important. You can do a non-contrast protocol. Now, the accuracy of this was studied by several groups, and this is one of them, validated against my biopsy. I think endomyocardial biopsy, although it is considered the gold standard, I have had enough experience myself doing a lot of biopsies and working with lots of labs that the reproducibility between labs is not great. The sensitivity is not great, so it's always questionable how good is endomyocardial biopsy as a gold standard. Anyways, having said that, when you validate it against endomyocardial biopsy, you see that the updated Lake Louise criteria have an accuracy of 92%. The old criteria here in this study were 77%. So you have a very high diagnostic accuracy. And this doesn't get better when you add the early enhancement. It's not as good if you just do the mapping, but it's still 80%. So that's still really much better than whatever else we have. Similar is if you only do late GAD and T2 mapping or late GAD and T2 ratio, that's the old one. But here you see a drop of the diagnostic accuracy. So bottom line, the updated Lake Louise criteria with one T1 and one T2 based criterion seem to have currently the best accuracy. Just a few words on KOVIT. So this is one of the patients, and we see quite a lot of them, but we are, of course, a referral center for that. in this case, LV function was reduced. In the late gadolinium enhancement, what you often see is a very, let's say, a modest regional abnormality, often inferolateral. There, in this case, you also see something here at the RV insertion, which is not specific for inflammation at all. It's a non-specific sign of a heart that at any time in the present or past did not feel well. Let's put it that way. And you see also a faint here in the anterior wall. This can also then be continued as the so-called mid-wall sign. This is just due to the fact that the right ventricle pulls here. And if you add a lot of stress to a heart, then it becomes a weak spot because there is a lot of mechanical stress. The right ventricle pulls, the left ventricle pulls, and if there's anything, inflammation, severe inflammation, or very high intraventricular pressure, or ischemia, then you end up, or hypertrophy that increases the demand, then you end up with small areas of fibrosis, but they're not specific for inflammation, so they cannot be used for that. But this here, the lateral often involving the pericardium, and in this case, the red shows the T1. These are the T1 maps, and you see that several areas of the show this red discoloration with consistent increased T1. And here, this is the edema. The darker here, the worse it is. So you see that there's a spotty and more apical, fairly extensive edema. So in this case, you have a high T1, high T2, and even some late enhancement. So this would be positive. In terms of COVID-19, I would refer you to this paper. We have, as a consensus group, put together the evidence and the recommendations and also typical findings in this paper. Another important and very much discussed aspect of myocarditis is induced myocarditis by chemotherapy, especially some cardiotoxic agents, and very recently immune checkpoint inhibitors have been identified as a strong risk for cardiotoxicity. So this is not myocarditis related to a virus. No, this is a direct toxic effect, and I would point you to some recent papers. So in a patient undergoing immune checkpoint inhibitor therapy and any clinical evidence for cardiac toxicity, an MR is very, very useful in verifying that. And as a last point I want to make, let's not blind ourselves by closing all the other eyes and just look at the MR. MR is important, and I think it's the strongest non-invasive diagnostic tool we have, but it should not be seen in isolation. You should always include the clinical presentation. That's still the most important. And you should include other markers wherever possible. And this was nicely done by Katie Fisher from Bern. This is partially work based on her time in Boston. So what she did here, she used the MR markers, but then added an ECG and had all these criteria basically combined, and the predictive value for an early outcome was much better when late gadolinium enhancement was, and this is just for late gadolinium enhancement, was combined with ECG. And this is just the start. I think in the future, we will have tools probably based on machine learning that will automatically not only help evaluate the images, but also take the results and then merge them with the results acquired by other non-invasive tests like an ECG and clinical criteria. So this is very similar to, so we're currently here at McGill, we're performing a prospective study in a large sample to detect diabetes in the ECG. And you can get to an accuracy of up to 70%, which is not great if taken alone, but together with other markers, this is valuable additional information that can be acquired even from a smartwatch. So I think you have to, let's say you're young, so you have to look into the future and open your mind to techniques that will not, where the decision is not based on a single modality, but is as it was always the case in a good clinical setting, is the result of combining information from several sources. And the clinical presentation is important. MRI is very powerful, and often that's all you need, the clinical presentation and the MRI. But if you can add other results, then that's even better. So with that, I think I would stop right now and happy to take any questions. Thank you. So now I surprise the moderators.
Thank you, Dr.
So if I can also, I have actually some cases that that I could show, but just let me know.
I think that would be great, Dr. Any questions specifically? I just had a couple of questions, if that's okay. Louise, do we have any prognostic data about either T1, T2, or scar specifically in myocarditis?
Yeah, thank you for the question, because I had taken out the slides in the interest of time. So as with basically lots of other myocardial diseases, late gadolinium enhancement representing irreversible injury naturally has a prognostic value. So the more late gadolinium enhancement you have, the more scar you have. The more scar you have, the more mechanical stress you have, the less recruitable contraction you have, the more arrhythmic potential you have. So naturally, the more scar and the more it is chaotically distributed, the worse the prognosis is. And this has been shown for heart failure in work from Stuttgart, and also with respect to acute cardiac death, sudden death, but the association with sudden death is not, let's say, not as strong as it was for heart failure, but it's still statistically significant. So clearly, late gadolinium enhancement has a strong prognostic value. Now, for the mapping technologies, it has been shown similarly for ECV, for the extracellular volume, that it has a strong prognostic value. For the mapping alone, the data are less clear. T2 actually may have a positive impact on prognosis, because if you have T2, which is edema, but you don't have associated scar, that means you have a problem currently and there is edema, but the edema is per se reversible. So there's a good chance that what you are having right now is caused by the edema, but the edema, because it's not associated with irreversible injury, goes away, and therefore the prognosis can be more positive. So there are studies, most of the studies have shown that in the absence of late gadolinium enhancement, edema has a favorable outcome, whereas if it's combined, it doesn't. There's just one study where edema was related with a worse outcome, but this study, I want to go into detail, had some issues with the criteria that were used to initially define positive late enhancement and all that. So bottom line is T1, T2 mapping, less strong as a prognostic marker, ECV and late gadolinium enhancement very strong.
Awesome, thank you. The other question I had is when we see some of the myocarditis, mainly with COVID, we see mostly epicardial enhancement, and sometimes that becomes a conversation, is this really enhancement or is this just epicardial fat that we're, I mean, do you have any suggestions how we can deal with that?
So this is, of course, let's say a constant challenge. What we do in clinical routine is so of course, if you only have the regular late enhancement, fat is bright, enhancement is bright. So there are two things you can do. You can look at the scout, because fat will behave differently in the TI scout than late enhancement. That's one thing. The second thing is fat the tissue that you can basically track from the pericardial from the perivascular fat around the coronary arteries. So if you see this is around the coronary arteries and then continues, so this is likely fat. This is number 2. Number 3 is a fat usually has, let's say, a more bumpy appearance in several areas, whereas the late enhancement is more a thicker line. But of course, the best way to discriminate that is to add a fat-sat late gadolinium enhancement. So where you saturate the fat, so the fat is basically a signal from fat is reduced, and if you still see it in the fat-sat, then it's very likely late gadolinium enhancement and not pericardial fat.
So we do have fat-sat sequences for late gadolinium enhancement, and you use those, yeah?
Yeah, we use them. Even if you do it just in 1 or 2 slices where you're not sure. Of course, we always have to try to shorten the scan time. So you need to have skilled technologists that realize or needs to have good instructions. Okay, if you see the late enhancement, if there's anything bright around the heart, just add a fat-sat, even if it's just 1 slice. So that would be an easy instruction to just adding 1 minute, but then to get more information.
Absolutely, thank you.
And also the mapping sometimes helps, because fat has a low T1 and a low T2. So that is also, if you have good quality maps, that is also helpful, just to look at the maps.
Awesome, thank you very much. I think Deepak has some questions for you. So.
I think we have a couple of questions in the audience. I think first question is by Ravi Ashwat. Is there a follow-up timing for myocarditis?
I see the question. So typical myocarditis, uncomplicated myocarditis, means the virus, or if we talk about the virus, is typically cleared within 3 days, but the inflammation takes about 3 weeks. In COVID, it may take a little bit longer. So a good time to follow up after an acute event would be 4 to 6 weeks. If you have clinical evidence that would suggest that you have a therapeutic consequence. If this is an uncomplicated myocarditis and people are fine, then you do not necessarily need a follow-up. But in some cases, we still do it, because if it was more severe, we would want to know, is this patient, does this patient have significant late gadolinium enhancement? And if so, I would want to see this patient in a cardiology follow-up just to make sure that there are no arrhythmia associated with that. And then I think the next question was, can we base exercise restrictions based on follow-up scans? I actually do that. If patients tell me that they do not feel fit after having had myocarditis, and I see evidence for acute inflammation, I actually tell them to wait for another month with severe physical exercise, or with serious exhaustive sports. If they are not fit and I don't see anything, it all looks clean in the MRI, then I typically tell them to, because this is also what happens, that you're just unfit, you have to just get back. So then I recommend them to slowly ramp up their physical activities and try to get back within a few weeks to their previous level of fitness. So to me, this is actually a guide that I use in my patients. Yeah.
And if you find any inflammation, do you still ask them to restrict from exercise? And if so,
yes.
How again will you repeat it?
Yeah. So if I'm pretty sure, of course, if it's let's say if there is some edema and it's not entirely clear, then I'm often a little bit more permissive and say, okay, let's just get started and see how it's going. And if it's not going well, then let's stop it. But if it's very clear, if there's clearly inflammation, I tell them just to keep the ball low for a while. Yeah, and then I think the next question was for T1 mapping. What cutoff do you suggest for edema? 60 milliseconds or higher, numbers like 80 milliseconds. So that depends on your field strength and your scanner. But for T1, for T2, on a 1.5, typically 60 milliseconds is actually a good marker. So that's a good cutoff. That's what we're also typically using. But again, just make sure you understand the normal range of your scanner. And then from Tizia, LGE means irreversible changes. Does it mean follow-up MRI should still show LGE? Yes, it does mean that. There are good studies, electron microscopic studies from Wolfgang Rewald during his time in Chicago many years ago, that late gadolinium enhancement is actually really specific for irreversible injury. Having said that, as I said before, in acute necrosis, what you have is that affected tissue is blown up by the edema, and it has dead cells in there. So you have a relatively large area with a relatively large volume of distribution, and therefore a large extracellular volume, and therefore late gadolinium enhancement. So now if you follow this inflammation over time, the edema goes away, and all these cells are cleaned up by the inflammation. So the whole thing shrinks by 70%. So there's still scar, but if initially the scar was relatively small and then shrinks by 70%, you may not see it anymore. So yes, a scar does not fully disappear. If you take a pathologist in that region and he carefully slices that, there will be small streaks of necrosis, yes, but they will not be visible. So what's the clinical impact? The clinical impact, of course, is if you don't see it, it is clinically very likely also not really relevant. So that's the point, that if you still see a scar, you have to assume, okay, this may be good enough to cause some arrhythmia, some non-specific chest discomfort, typically not heart failure or dramatic stuff like that. But if you don't see anything, then yes, you know he had LGE at the beginning, so there's some mild necrosis. And if this patient then shows up and says, I had a presyncope and I don't know how that happened, I would then do a 24-hour Holter and just be a little bit more aware. Yeah. And then can you have development of LGE after a negative LGE on an initial scan? I have not seen that. Typically, the clinical presentation represents the acute event that leads to the necrosis. LGE doesn't show up like that silently later in viral myocarditis. And in any case of acute myocarditis. So in a case of sarcoid disease or infiltrative disease, this may be different. So you may not have a clinically impressive disease, but the infiltration may still progress and induce some late gadolinium enhancement. Not happening in viral myocarditis or in any other acute form of myocarditis.
I think that's all the questions which we have for now.
I just have one last question, Dr. Friedrich. Typically we use colchicine for pericarditis, and I think we all love colchicine, but do you ever use it for myocarditis at all when they're symptomatic with chest pain or anything?
Yeah, this is a question I wish I would be more comfortable answering. So it's a very, very good question. There is a study actually done from the Montreal Heart Institute. I'm not at the Montreal Heart Institute. Just to have a little correction, I'm at McGill University Health Center, so these are two different. I was at the Montreal Heart Institute before, which is the French side, the Université de Montréal. So they performed a study using colchicine that turned out positive even in myocarditis. And as you probably all have heard, there are even studies ongoing looking at the impact of using colchicine in coronary artery disease as a means of reducing the inflammatory burden. I think that's an interesting approach. And I actually use colchicine as basically the third line treatment in patients with chronic myocarditis. And what I see is that typically after 1-2 months, there is an improvement. But an improvement after 1-2 months could be just happen despite the colchicine, not because of the colchicine. So to me, I would like to see at least one other controlled, properly done prospective trial using MRI criteria for inflammation, and before I would make a strong recommendation here. But since we do not have good therapies for myocarditis anyways, sometimes if you have nothing, then you have to use what you find. This is, so there are a couple of agents involved now. I'm involved in a study using now CBD with its inflammatory, anti-inflammatory impact in patients with acute myocarditis. And there are some other therapeutic strategies that may now come. So we'll have to see. Hopefully, we have something. Having said that, luckily, the garden variety myocarditis typically is a disease of more benign prognosis. COVID, as I said and mentioned, is a bit different, not just because of the heart and pericardium, but also in terms of the lungs. So we deal with really a much more nasty animal here. But in other forms of myocarditis, of acute myocardial inflammation, the prognosis is typically depending on the underlying disease. And if this is just a viral infection, then the prognosis is typically relatively good.
Awesome. Thank you very much.
We have one last question, Dr. Frederick. Can you please elaborate MRI role in post-transplant patients with regards to rejection myocarditis?
Oh, yeah. Thank you. I should have said that, but the transplant is such a, let's say, it's an interesting topic. And I strongly believe, and we have done this actually years ago already, and with very good experience. Of course, acute rejection is an inflammatory process. So the criteria that we're using looking for edema, inflammatory injury, of course, can be applied. And the challenge is with post-transplant that, of course, post-transplant, you have confounders. You have inflammation anyways, early after the transplantation. You have coronary artery disease that is associated with that. So it's a tiny bit trickier, but in a patient with lack of evidence of inducible ischemia or ischemic events and clinical presentation with inflammation, it has been shown over and over that T2weighted imaging or T2 mapping is a very good and very sensitive marker. And we have actually started a long time ago already in Calgary tracking patients instead of doing that with biopsy, a routine biopsy, also in parallel with T2weighted imaging or T2 mapping. And I think in the hands of an experienced center, this would be better than trying to do that with biopsy because of many reasons, especially but the convenience and the safety for the patient. I think the diagnostic accuracy is probably better, but even if it was the same or slightly worse, I think the benefit overall would be still there for patients. And we have also just published a few months ago a paper on post-transplant patients where we also added oxygenation-sensitive MR with breathing maneuvers, which is a test for microvascular function. So if you combine the two, you have so much information in a non-invasive test that doesn't even need a contrast agent. That I think this is way better than a biopsy. If I had a transplanted heart, I would not let people poke in my heart. I would rather go for MRIs. So just thanks for the question.
Sure.
Thank you very much, Dr. Friedrich. We understand your busy schedule and all your other commitments, and we really appreciate you spending your time with us. For all the attendees, you really heard from the guru and the best here. So I know
Thank you.
We usually have a few hundred to few thousand views on our videos later, so you might even get questions later on. But thank you very much.
Happy to take them. This is important, and feel free to fire me an email and send questions. All the best to everybody. Bye-bye.
Thank you. Thank you. I will take this time to go ahead and introduce our next speaker.
Hi, Amit. Good seeing you.
Hey, Matthias. Great.
Passing the baton over.
Thank you.
Awesome. Dr. Amit Patel. Dr. Amit Patel, probably familiar to most of you, was born in Toronto, raised in Northwestern Arkansas. He earned his medical degree from Emory University School of Medicine, completed his medical training at the University of Chicago, fellowship at Temple, and fellowship in advanced cardiac imaging at University of Virginia. He is currently a professor at the University of Virginia Department of Medicine, where he serves as the Director of Non-Invasive Cardiology and Director of Cardiac MRI and CT. Prior to joining UVA, Dr. Patel was a faculty member in the section of cardiology at the University of Chicago, where he served as the Director of Cardiac MRI, Cardiac CT, and Cardiac PET. He has a variety of research interests, mainly focused on non-invasive cardiac imaging tools to better understand the cause and extent of a patient's heart disease. And it focuses on the development or validation of novel methods to quantify cardiac function and the evaluation of myocardial ischemia and infiltrative heart disorders such as cardiac sarcoidosis and amyloidosis. Amit is one of the key players in the development of the cardiac MRI boards, which we have the board certification for now, and also in stress testing. I will let you take over, Amit. Thank you very much for doing this.
Mahi, thanks. That's such a generous introduction. You're too kind. Good afternoon, everyone. I'm going to be talking about cardiac MRI and ischemic heart disease. Here are my disclosures. So I think we're all aware that this past year, the ACC-AHA published new guidelines on the evaluation of chest pain. And I think they're very nice in the sense that they really focus on the fact that we don't need to do any imaging in asymptomatic patients and low-risk patients. However, in the situation of stable chest pain, and if you have patients at intermediate or high risk, you can really pursue either anatomic or functional testing. If you have acute chest pain, and you have acute coronary syndrome or high-risk features, then of course these patients would go to invasive coronary angiography, and those at intermediate risk would just go on, could have anatomical or functional non-invasive testing. This is not particularly different from what the European Society of Cardiology published in 2019. Some kind of variation is that CT was more preferred for slightly lower risk or lower clinical likelihood patients. And then those at higher clinical likelihood, non-invasive testing for ischemia was preferred. And of course, those at particularly high risk ought to go straight for invasive coronary angiography. So similar, but slightly different. There are multiple ways to go about looking for ischemia. We know about them all: treadmill stress testing, stress echo, stress nuclear, PET, and MRI. Each of these kind of has different advantages. We're focused on stress MRI here. And so here, first of all, a disadvantage of stress MRI is that it does require pharmacologic stress agents. Exercise can only be done in very, very specialized centers. Advantages is we can be very quantitative and we can very accurately assess LV function and scar. And so I want to start by, first of all, I put these QR codes here, so it'll be interesting to see how that turns out. I never did that before, but so first I want to talk about kind of the ischemic cascade. And I think one of the important things to remember is that there is a balance between myocardial oxygen demand and coronary blood flow. Okay, so first of all, as the severity of coronary stenosis increases, coronary blood flow decreases. Similarly, as your myocardial oxygen demand increases through exercise, then you can start to get a mismatch in your balance between your myocardial oxygen demand and coronary blood flow, ultimately leading to symptoms in its kind of most severe stage. And earlier on, you might have just perfusion abnormalities, and somewhere in the middle, you may have start to develop regional wall motion abnormalities. So just to kind of dig a little bit deeper into this concept, this balance here in coronary blood flow in particular. So if you look at this very famous graph published by Dr. Gould many years ago, what you can see is that as the severity of a coronary stenosis increases, there is preservation of the resting myocardial blood flow. And it's not until you get to really critical, like greater than 90% stenoses, that you actually start to see a decrease in your resting blood flow. And this is because we all have a certain coronary flow reserve built in through our microvasculature. And so to kind of explain this, if you take someone who's completely healthy, has no coronary disease, and then you have them exercise, in order to meet that workload, the coronary flow reserve can triple, quadruple, quintuple, depending on how elite and how athletic you are. Now, the reason you don't have a decrease in your resting blood flow as the severity of coronary stenosis increases is because some of this coronary flow reserve is used up just to maintain your resting blood flow. Now, what that means, though, is when you do finally exercise, you don't have as much coronary blood flow reserve to meet your exercise workload or your new myocardial oxygen demand, and so you develop ischemia. Now, ischemia happens in the myocardium. It doesn't happen in the epicardial coronary disease. And so when we're looking for consequences of ischemia, we need to look at the myocardium. And so here is an image of someone who has a severe perfusion defect, presumably in the RCA territory. And if you have acute ischemia that's severe enough to cause a reduction in function, and then transiently you then restore the perfusion through relief of ischemia, sometimes you can still have a decrease in function, despite yet with normal viability. And this is referred to as stunned myocardium. And this is in contrast to something called hibernating myocardium, which is a chronic condition where you have a severe decrease in perfusion that's consistently there. It's not enough to cause infarction, but it is enough to kind of cause the myocardium to go through some changes and become dysfunctional to kind of reduce its resting oxygen needs. Now, if this ischemia is more severe, more persistent, you can actually get to necrosis of the myocardium. And here on this T2weighted image, you see edema, the early part of kind of injury, all through the anterior wall here. And then if you kind of allow the obstruction or the marked ischemia to persist, you can get necrosis with microvascular obstruction, shown by this scar with this dark area here. And then eventually, once that acute stage is resolved, you can be left behind with a chronic scar, as shown here. Now, after you have an infarct, it turned a STEMI, let's say, about half of the patients will undergo adverse left ventricular remodeling, which here is defined as a greater than 20% increase in your left ventricular end diastolic volume. And in most patients, the vast majority of patients, this adverse remodeling happens within the first 3 months. However, smaller portions of people can be midterm remodelers and late remodelers. And it's not clear if this adverse remodeling, if you were to divide those patients up between the 50% who had adverse remodeling and those who did not, it's not clear that that is associated with death. However, it is seemed to be associated with risk of heart failure hospitalization. So if you have adverse remodeling, you can see your risk of heart failure is greater than if you were not a remodeler. So what are the goals of imaging in ischemic heart disease? Well, first of all, we want to detect ischemia. We'd like to assess global and regional left ventricular size and function. We'd like to understand how much myocardial scar is present and whether there's any viability there. We'd like to identify patients that might benefit from revascularization, and we'd like to get some insights into patient risk stratification. So let's think now how we go about imaging these patients. And first of all, currently we require the use of some sort of tracer, and I'm going to use nuclear tracers as an example. And if the kind of the perfect tracer is probably O15 water, and the reason is that tracer exactly follows blood flow because most of blood is water. And so the water will just go wherever the blood goes, almost a one-to-one relationship. Okay. Other tracers have kind of a plateau or a plateau effect such that it's maybe a one-to-one ratio at lower blood flows, but then that relationship deteriorates a little bit. So we take this tracer and we inject it into a vein, and it'll eventually go wherever blood goes. And so if you have under resting condition, regardless of whether you have a stenosis or not, you get normal perfusion everywhere. However, when you induce hyperemia in the normal territory, you're going to have an increase in blood flow, as I showed you. So you're going to have plenty of tracer going to that normal area. However, distal to a stenosis, because you don't have as much flow reserve there, you're going to get a lot less tracer going distal to that stenosis. Okay. Now with MRI, the tracer we use is gadolinium. This is a paramagnetic agent that shortens our T1 of nearby water protons, and it has an extraction fraction about 50%. We inject the gadolinium contrast agent into an IV, and then we image the heart. And what we do is we acquire, we want to acquire an image or several images of the heart every heartbeat for many, many heartbeats. And so we will use a very fast sequence where we can quickly get a snapshot of the heart at the base of the ventricle, at the mid-ventricular level, and at the apical level. So you get 3 slices of images every single heartbeat. We then do this repetitively as we give the contrast agent. So every single heartbeat, we get these 3 separate images at 3 different levels of the heart, so that early on here, you can see these boxes are over time. And so early on, you get gadolinium in the right ventricle. Eventually, it starts to show up in the lung vasculature, and then it shows up in the LV cavity. And then as it keeps perfusing, it gets into the myocardium. And so you can see here, this area of the left ventricle seems to be turning white and has lots of gadolinium, whereas this area doesn't. And you can see that kind of better here, where this area doesn't get as much gadolinium as the rest down here. And so this area is ischemic, and this area is normally perfused. And these are just kind of the time intensity curves to help you see that. So here's the gadolinium flowing through the LV cavity. Here's the gadolinium quickly coming into the normally perfused myocardium. And here you see gadolinium more slowly going into the ischemic territory. So here is how we typically look at it as these videos. And so here you have an image. You're going to see the gadolinium coming into the RV, LV, and then creating this perfusion defect where it fills a little bit slowly. So this is all in real time, okay? And then here's a resting image just for comparison. So you can see the gadolinium at rest goes everywhere. And then this patient was sent for coronary angiography because of this big perfusion defect, and you can see kind of severe sequential coronary stenosis in this RCA. Now, there are several advantages to stress MRI. First of all, it has a very high spatial resolution. And remember, by the wavefront theory of ischemia, ischemia first starts along the subendocardium and works its way along to the epicardium. So here is an individual who's got a subendocardial perfusion defect all the way around the left ventricle here at the base, mid-ventricle, and apex. And you can see along the epicardium, there is good perfusion. And at rest, you see it's kind of equal everywhere because the perfusion is similar everywhere. This patient had a critical left main stenosis. And you can think of, now in contrast this to nuclear or SPECT, which has a much lower spatial resolution. You can see where you cannot differentiate the endocardium from the epicardium. So you see it really looks the same everywhere. And you could accidentally interpret this as a normal scan. However, if you look really carefully, you can see that there's increased uptake in the RV at stress and not rest, suggesting that the blood flow to the LV is not augmenting as much. But you have to really be paying attention to pick up this subtle difference. The other advantage of MRI is that because of its spatial resolution, we can one, differentiate different tissues. So the abdomen is easily to separate from the left ventricle. And similarly, there's no such thing as attenuation with MRI. And so here, if you look at this SPEC study, you can see it can be pretty challenging to interpret. Here you have maybe a defect here, which maybe you would say is ischemia, or maybe it's attenuation. But then when you look at the rest image, you say, well, it kind of gets better, so it's probably attenuation, but you have this huge GI uptake here, which makes image interpretation pretty difficult. And here's just that same patient, and look at their MRI at rest. There's no defect there, and at stress, there's clearly a defect there, and you can see that the abdomen does not get in the way. There's a coronary angiogram, LA left system looks good, and you see a severe stenosis in the RCA. So how does, with these advantages over kind of some of the other stress testing techniques, how does MRI compare? So this is data from the CE Mark study. This is a prospective study where every single patient who presented with chest pain underwent stress MRI, stress nuclear, and invasive coronary angiography. And what you can see is the sensitivity of stress MRI is much higher than SPECT. The specificity of the two modalities is actually similar. And this really translates into a considerable improvement in the area under the curve on ROC analysis. What about if you compare against invasive FFR? Because I think today invasive FFR is probably our gold standard. And what you see is you have these are 5 different non-invasive testing modalities. And what you see is these 3 techniques here are kind of stress MRI, stress PET, and stress CT, really performing extremely well. And versus these 2 here, which represent stress echo and stress SPECT. And so there's really is quite a separation in diagnostic performance between kind of some of the newer technologies and some of the more traditional technologies. There's been a huge amount of prognostic data that's been published with regards to stress MRI. Here's data from the SPIN study. It's over 2,000 patients, multiple centers across the US. And what you can see is that the burden of ischemia is associated with patient outcomes. So if you have no ischemia, their outcome is quite good. And then if you have severe ischemia, they do much worse. And you can see the response is graded depending on the degree of ischemia that you have. And this goes through multiple different conditions. Here's another large registry, almost 10,000 patients with a considerable amount of follow-up. And what you can see, if you have ischemia, your prognosis was worse if you had, regardless of groups of patients, such as those without prior coronary disease, those with coronary disease, those with normal EF, those with abnormal EF, those with prior infarction and without infarction. There's been other data to show that in men, in women, in diabetics, in patients with significant LV dysfunction, on and on. It continues to work. The risk stratification of stress MRI works in all of these groups. Now, one of the unique things, I think, credit to the stress MRI community is that it's the only non-invasive test that's been put through a randomized controlled trial against invasive FFR. And so in this study, roughly almost 1,000 patients were randomized to go straight to the cath lab with FFR guided revascularization, or first go for a stress MRI and then decide if they should get a cath. And what you can see is in the cath arm, about half the patients had negative FFR or no coronary disease at all, obstructive coronary disease at all. And the other half had abnormal FFR, and those with abnormal FFR were revascularized. In the stress MRI group, about half the patients had no ischemia, which corresponds to the half of the patients that didn't have obstructive coronary disease or abnormal FFR in the FFR group. And thus only half the patients ultimately made it to the cath lab, where 80% of them were ultimately determined to need revascularization. Overall, in the MRI guided group, fewer patients got revascularized than in the cath group. However, this difference did not translate into any differences in patient outcomes. You can see if the patient was in the stress MRI guided group or in the invasive FFR guided group, their prognosis was exactly the same. And this, is kind of really interesting new data talking about the cost savings associated with the use of stress CMR guided revascularization instead of invasive FFR guided revascularization. And you can see it's estimated, whether this is through European registries or through this US SPINS registries, you can see you're looking at a 35 to 40% cost savings versus if you just sent all the patients straight to the cath lab with FFR. And then this held true regardless of whether you had kind of classic angina or less classic angina, or whether you had known coronary disease. You can see consistently there is some degree of savings if you use stress MRI instead of cath. And this kind of world map here, the darker the gray, the greater the amount of savings. And you can see across the world, different health systems, it seems to be a consistent pattern that you can really have some savings. Now, I think despite all of this data, one of the exciting things is that the stress MRI is continuously being improved. Here's kind of a technique where using kind of deep learning to improve the image quality. You can see here's a standard reconstruction, and you can see there's certainly perfusion defects there, but its image is a little noisy. And you can see when you apply the deep learning, you can see a significant improvement in your image quality. Now, I think what I've shown you kind of throughout the talk here is that these are dynamic images, and you can generate these time intensity curves. What's really great is that you can then take these time intensity curves and apply some mathematical modeling and actually calculate the myocardial blood flow in mils per gram per minute. And you could apply that to every single pixel in your image and know the blood flow in every pixel of the heart muscle. And so here's just kind of an example. Let's just focus on this middle quadrant here. You can see there's a little bit of you can see that there's definitely a perfusion defect here at stress, but not at rest. And then when you look at the quantitative blood flow, you see here it's all green, which is around 1 mil per gram per minute of blood flow. And then with stress, you see the ischemic area where we see the defect remains green, and the rest of it turns orange, which is around 3 mils per gram of blood flow. And so you can see how the quantification is picking up on exactly what we see. On the bottom is a patient with 3-vessel coronary disease, and you see the resting normal perfusion. You see kind of this diffuse perfusion all throughout the myocardium here. And then when you look at the quantitative blood flow, you see it's green at rest, and it remains green at stress, saying that the blood flow doesn't increase all that much, which would support the multi-vessel coronary disease. So look at this kind of in a different way. Here, healthy volunteers, you can see their stress myocardial blood flow is around 3.5. Ischemic segments, distal to an obstructed coronary disease, you see the blood flow is low at 1. And then in patients who have no coronary disease or in remote territories of a patient with coronary territories, you see the blood flow at stress is around 2.5 or so. So you can really appreciate how this quantification seems to work really nicely. Now, I think the quantification allows us to overcome some of the limitations of visual assessment. So here's an example. At rest, you can see a normal perfusion in all 3 slices. At stress, you can see a little bit of a defect here in the inferolateral segments. And I think if you looked at just the images, you would say that this patient has single vessel coronary disease. However, with the quantitative technique, you can see all these red segments were actually abnormal, which would be more consistent with 3-vessel coronary disease. And indeed, when the patient was sent for cath, all of these red segments were supplied by a severely stenotic disease, and this patient actually did have severe 3-vessel coronary disease. And I think here you can really appreciate the added value of quantification. if you just look at the image and you divide your patients up to into those with single vessel disease versus those with 3 vessel disease, you see there's not a drastic difference in the ischemic burden that you can physically see. On the other hand, when you quantify the blood flow, you see those with single vessel disease have much lower burden of ischemia than with patients with 3 vessel disease who have much more ischemia, which is really what you would expect. And so you can appreciate the added value of quantification. Those findings have been validated more recently with more sophisticated techniques using this pixel-wise blood flow measurements. And you can see here in patients with single vessel disease, the ischemic burden, whether you visually look at the image or quantify, is quite similar to each other. However, as you get to 3 vessel disease, you can start to appreciate how you start to underestimate the ischemic burden by visual assessment versus quantification. And there's now been, here's a significant amount of outcomes data related to this quantification. There's over 1,000 patients here. And you can see those patients who had stress blood flow less than 2 actually had worse outcomes than those who had a stress myocardial blood flow greater than 2. The same would hold through if you calculated the myocardial perfusion reserve. And importantly, you can see the quantification in this, when it comes to predicting outcomes, did just as well as visual assessment. And you could look at this one of 2 ways. You could say, oh, well, the quantification didn't improve visual outcomes, but actually, I think you need to think about this as a way of democratization and equity, where here now, because of the quantification, the technology can be useful in more locations, even where there aren't these super experts that are very experienced in doing stress MRI present. So this is really kind of helps get stress MRI more available to patients everywhere, rather than just at specialized centers. And this page chart here kind of really adds to that. You can see the accuracy of a level 1 trained cardiac MRI person versus level 2, 3, and then quantification. You can see the quantification performs just as well as a level 3 expert, and it really outperforms a level 2 trained person and a level 1 trained person. Now, I think we started, so far everything I've discussed is related to epicardial coronary disease, but we're looking at the myocardial. Perfusion happens in the myocardium, and the vast majority of blood flow in the myocardium is actually transmitted in the microvasculature, as you can see in this anatomical picture here. And I think this means that what's happening with perfusion is really more related to microvascular function than to epicardial coronary disease. And this is important because there's a whole bunch of patient subgroups where coronary microvascular disease is prevalent. And soon we may start to have specific treatments targeted towards these different causes of coronary microvascular disease. So I think it's important to start thinking about the coronary microvasculature. And when it comes to prognosis, the severity of coronary microvascular disease is additive to the severity of atherosclerosis or obstructive coronary disease, such that if you have a patient with obstructive coronary disease and severe coronary microvascular disease, their prognosis is worse than if they had more normal microvascular disease. And this goes through all the different kind of severities of atherosclerosis. Now, because we can quantify the myocardial blood flow, we have an opportunity, hopefully, to actually detect microvascular dysfunction. So here, again, looking at the stress myocardial blood flow in healthy volunteers, you can see it's in this study, everyone's over 2.25. And then you can see in those who have severe multivessel coronary disease, you can see their blood flows are less than 1.82 here. And those patients with microvascular disease kind of have an intermediate blood flow, ranging between kind of the normal range and the severely obstructive disease range. There's some overlap and a lot of work that needs to be done here, but this gives you an idea that we can start to differentiate these patients who have microvascular disease from healthy volunteers and possibly from those with severe coronary disease. Now, A stress MRI study is not just about perfusion. The typical protocol, of course, includes perfusion or ischemia, but it also involves cine imaging so that we can quantify function, and something called late gadolinium enhancement, which allows us to look for myocardial scar. And the protocol, the entire protocol, when done at an experienced center, can be done in 30 minutes or less. So here, looking at the function, we typically are going to get multiple views of the left ventricle. Here you see a 2-chamber, 3-chamber, 4-chamber. We have some short axis slices here. And the idea between getting all these different views is to help us visualize each of the AHA segments from 2 different imaging planes. And why do we care about these AHA segments? Because they correspond to specific coronary territories. We then look at each segment and look for regional wall motion abnormalities. So here you have a short axis image with normal wall motion. Here you can see there's mild hypokinesis in the inferior and inferolateral segment here. And then here you can see severe akinesis or dyskinesis there. And because you have really exquisite delineation of the endomyocardial surface, it's really easy to appreciate these wall motion abnormalities. We additionally get an entire short axis stack of cine images starting at the apex of the ventricle all the way through the base, as shown here. And once we have these images, we can draw an endocardial boundary all the way around each slice of the heart. And since we know the area inside the circle we just drew, we know the slice thickness, we can determine the volume. And we can do this volume for every single slice, add them up using Simpson's method, and that gives us the total volume. If we do that at end diastole and at end systole and subtract the 2 volumes, we can calculate stroke volume. If you divide the stroke volume by the end diastolic volume, you get ejection fraction. If you take the stroke volume and multiply it by the heart rate, you get cardiac output. And of course, we would say, well, other imaging modalities can calculate ejection fraction as well, and that is certainly true. Here's kind of correlation between MRI and echo. If you look at ejection fraction, there is a modest to good agreement between the ejection fractions calculated by MRI and by echo. But if you look a little closer, as we all know, sometimes there is quite a discrepancy, and you can see here the limits of agreement are plus minus 20%. Of course, that's at the extremes of error, but usually you can expect a plus minus 5 or 10% at most between the 2 modalities. Doesn't matter, these modalities are giving you slightly different ejection fractions sometimes. Does that affect our ability to risk stratify patients? And it does. You can see here with the echo, if your EF was greater than 35%, your prognosis was certainly better than if it was less than 35%. However, when you did it by MRI, you can see those patients who had an EF greater than 35% differentiated better from those patients who had an EF less than 35%. The gap between survival was larger for the MRI cohort, suggesting that the increased accuracy of MRI does translate into better risk prediction. Now, doing these measurements manually means that there is still some inter- and intra-observer variability in how these measurements are done, even with MRI. And so there is a role for automated techniques here. Increasingly with all of the imaging modalities, we're using artificial intelligence to quantify ejection fraction. And here's work from Shua Wang from my lab, looking at kind of clinical expert quantifying ejection fraction. You can see those with a good ejection fraction do much better than those with a poor ejection fraction. And when you run it through, we here tested in 3 different kind of commercially available AI algorithms, and you can see the software separated the different groups of patients relatively well compared to an expert. So this again allows for more increased reproducibility and democratization availability of kind of MRI to less expert centers. Now, I talked a lot about these time intensity curves with respect to ischemia. Here's a green curve showing normal perfusion and an orange curve showing abnormal perfusion. However, I didn't tell you what happens in the infarcted myocardium. In the infarcted myocardium, what you see is there's a very slow uptake of gadolinium into the myocardium. And then it doesn't wash out very quickly at all. It actually kind of stays there for a long time and just very slowly washes out. Whereas in the ischemic segments, the gadolinium washes out really quickly. So if you were to image the heart, let's say at this time point, then what you would see is that there would be much more gadolinium present in an infarcted myocardium than in an ischemic myocardium. And sure, and this is because in a healthy myocardium, the extra gadolinium that gets trapped in the extracellular space is relatively small because we don't have that much extracellular space. However, once you have an infarct, there's been there's a considerable collagen matrix that forms, and then there's lots of extracellular space. So you have lots of opportunity for gadolinium contrast agent to go into the extracellular space. And this translates into kind of the ability to detect this kind of scar tissue. And so here's just kind of data from a canine model showing a myocardial infarction using TTC staining in vivo, ex vivo. And then here's kind of the corresponding MRI image. And you can see the MRI technique really very precisely detects the myocardial scar itself. And it turns out the transmurality of this scar, of this infarction, helps you determine myocardial viability, such that if you have no scar tissue and you have a dysfunctional segment that you revascularize, there's a very good chance you can have improved function. On the other hand, if you have a transmural scar there where more than half your wall is infarcted, then that segment is unlikely to improve following revascularization. Now, here's just an example of a patient with a very large wall motion abnormality with severe thinning. You can see this in multiple different views in the 2-chamber, 3-chamber, 4-chamber. Here you see the corresponding transmural myocardial infarction in each of these views. This myocardium would not improve with revascularization because it's all scar tissue. There's no living myocardium there. In contrast, here's another patient with severe LV dysfunction. And you see here, they have really not much myocardial scarring at all. And following bypass surgery, you can see a huge improvement in their ejection fraction. The walls have plumped up. Everything is contracting much, much better. And I think this kind of what we just saw has been validated. Here, this article in JAMA several years ago, you can see wall motion abnormality between these two areas at thinning and diastole and akinesis, systole. And then you can see there's a little bit of a non-transmural, less than 50% wall thickness scar there. And after revascularization, you can see how the myocardial is plumped up really nicely. And looking at it more graphically, you can see if a segment less than 6 millimeter thick had a non-transmural scar within it and you revascularize it, you can see that it improved. If it had a transmural scar following revascularization, that segment did not improve. And so you can see the more of these segments you have with transmural scar, the less likely your ejection fraction is to improve following revascularization. Now, one of the advantages of MRI, which I talked about earlier, is that the technology has very high spatial resolution. So we can actually detect pretty small scars. So here's a small myocardial infarction here, here, and here. And then if you look at the corresponding TTC stained image, you can see here's the infarction, the corresponding infarction, and corresponding infarction. But when you look at SPECT, which has a much worse spatial resolution, you can see these all look really completely normal. And sure enough, and this really translates into kind of much better sensitivity of detecting scar using MRI than SPECT, especially when you're talking about non-transmural infarctions, less than 50% wall thickness, where SPECT may miss almost half of the segments that actually have a non-transmural scar within it. Those segments, of course, if you have a transmural infarction there, that's going to be readily detectable by any imaging modality. And sure enough, as you would expect, SPECT identifies the most of those. Now, Okay, you can detect these small myocardial infarctions that you wouldn't have known about otherwise. Does it matter? Here's a study from Iceland trial or study showing those patients, where you're picking up unrecognized myocardial infarction. Here's a small one. Here's actually a larger one that was unrecognized. So these definitely happen. And you can see the prognosis of having an unrecognized scar is equally bad as having a recognized or known myocardial infarction. And of course, having a myocardial infarction puts you at worse prognosis than if you had none at all. Now, this data was looked at and more recently in the SPINS trial, the multi-center SPINS trial study that I showed you. Again, you can see those patients who have no evidence of myocardial scarring have much better prognosis than those who have myocardial scarring. And regardless of whether it's a recognized myocardial infarction or an unrecognized myocardial infarction, you can see the prognosis is equally worse. And what's important is that when patients have recognized myocardial infarction, you can see they're very likely to be on aspirin, statin, beta blockers, ASAR, et cetera. However, when they had an unrecognized myocardial infarction, they were much less likely to be on aspirin, statin, or beta blockers. And this kind of raises at least the concept that this is an opportunity for us to improve our medical therapy in patients with unrecognized myocardial infarction. Now, so to summarize, stress MRI exam takes about 30 minutes. It can allow you to detect ischemia, function, and viability. It can accurately detect hemodynamically significant epicardial coronary disease, and it probably can detect microvascular disease. It can help you guide with revascularization strategy. It can accurately assess global and regional function. It can accurately detect the presence of a myocardial scar and assess for viability. And there's an extensive body of literature supporting its prognostic value. And so with that, I'd like to say thank you and answer any questions that you may have.
Thank you, Dr. Patel. So I'm just trying to check on the chat box to see if you have any incoming questions. Looks like we have one question. Is quantification of myocardial perfusion standard in all cases where MRI is done to evaluate for ischemia? Do most centers do it?
That's a great question. There is all three of the MRI vendors do have software to imaging acquisition techniques to do the quantitative perfusion imaging. And now, if I'm not mistaken, some of the software vendors have the software to automatically quantify myocardial blood flow and creating these pixel-wise maps. And if I'm not mistaken, at least one of them is FDA approved now. So whether a center has it or not is purely dependent on whether the center wants to pay to have it or not. So I cannot say that every place has it or doesn't have it. But they have the opportunity to have it, let's say.
Absolutely, I agree on that. And the next question is there data? Let me just scroll back. Is there data specifically showing there is reduction in mortality if revascularization is performed on the basis of ischemia on stress MRI? I think they are referring towards Stitch.
Yeah, that's a really important question. And I think, we now know from the ischemia trial that revascularization, even in patients of moderate and severe ischemia, does not improve patient survival, right? So there's no reason really to think that you can improve patient survival by doing a stress MRI and detecting the ischemia and then saying, well, let's revascularize. And if you looked at the New England Journal of Medicine paper, where in randomized trial with MRI stress testing against invasive FFR, the MR-informed study, you can see, if you remember, the survival was 95% in both groups, right? So this is a key pathophysiologic question. If, you know, does treating ischemia with revascularization actually improve outcomes? And I would say it's not clear that we need to do that. However, that doesn't mean that you can't improve a patient's symptoms, right? So I think even the new, if you look carefully at the new ACC/AHA guidelines, they're saying detect the ischemia, treat the ischemia medically, and then if the patient continues to have symptoms despite medical therapy, then revascularize them. So why do you need the stress test? Because you need to know what you're treating, right? You have chest pain, and you can't just assume every chest pain is due to ischemia. You need to diagnose that. And so it's still a really important diagnostic test so that you can decide how to treat the patient.
Also to kind of assess which is the culprit vessel in terms of where you have ischemia, which one to revascularize and not.
Yeah, exactly.
We have one more question. Can you diagnose hibernating myocardium with stress MRI, or it's doing diagnosis only relies on thin wall and absence of LGE?
Yeah, so the diagnosis of hibernating myocardium requires three things, right? One, it needs to have a thin wall or a hypokinetic wall. Two, it needs the absence of a transmural myocardial scar. And three, it needs ischemia, right? You need either you can assume the ischemia because you know that there's a 90% stenosis there and say, oh, this is highly likely to be ischemia. Fair enough. That's a reasonable conclusion. Or you need to do the ischemic testing. So it just depends on what you know about the patient, whether you need the stress test or not, you know, the ischemia test part of it.
Right. Then does cardiac MRI has role in diagnosis of Prinzmetal angina?
So Prinzmetal's angina is coronary vasospasm related, and so since we're not really looking at coronary vasospasm with MRI, I think to actually physically see that, I think that would be difficult. You may need to really see the EKG changes, or you need to do the appropriate kind of endothelial testing in the cath lab. Where it might have a role is if you want to see if the Prinzmetal has caused previously infarction, or is causing in that downstream territory abnormalities in wall motion or something like that. I think in that sense, maybe there's a role for it, but actually seeing the coronary artery itself, I think that probably would be a little bit challenging. You really need that provocative testing, I think.
Yeah, I agree. I think that's all the questions which we have for now.
I see a few questions actually, Amit, about the quantification, and that was actually one of my questions too. I mean, do you quantify on everybody, or who do you do it, and what softwares do you use, and how do you feel about them?
Sure. So I think we have, as of yet, not been quantifying in everyone, but when we are referred to someone for looking at microvascular disease, we are trying to quantify. However, I am about 99% ready to quantify on everyone. It's just a matter of we need to sort out at University of Virginia our workflow so that it can be done in a kind of an automated sort of way. I think 3 softwares can quantify myocardial blood flow that I know about, and maybe there's more. And so here again, I showed you my conflict of interest. I do research with Circle Imaging, and Circle software actually has a very nice tool to create these pixel-wise maps that's pretty automated. And I think my experience is it's pretty robust. And then the most widely published is this inline software by the NIH group, which is more available through a research agreement and more specific to just Siemens equipment. So I think you could use that as well. And then I think the Sweetheart software also does it, but I'm not 100% sure about that.
Absolutely. So I'm guessing, is the Circle software more like a clinical, or is it still research? And then how much time does it add for your post-processing if you include that?
So Circle software is, I'm not so involved with Circle that I know for sure, but I think it's FDA approved, but you please double check your own self. I'm sure you could go on their website and see that, if that's true or not, but I think it is. And as far as creating the quantitative perfusion maps itself, the color maps, that actually is pretty automated and doesn't take much time at all. Mild amount of time, worth it. If you want the actual segmental blood flows, then you need to make sure the contours are perfect and the segmentation is perfect. That takes a little bit more time. But that visual bullseye plot with the green and the orange, that to me has always been the most valuable part anyways. And so that I think is pretty automated and pretty robust without taking too much time.
I think Deepak has
we have one more question, Dr. Patel. If absence of LG on MRI is otherwise severely impaired, LV excludes the diagnosis of ischemic cardiomyopathy.
Sorry, I was reading the wrong question here. So could you tell me what that again?
Yeah, I think somebody just directly texted me is if absence of LGE on MRI in an otherwise severely impaired LV excludes the diagnosis of ischemic cardiomyopathy.
It has that outside chance that you have severe three-vessel coronary stenosis, like 90% stenosis in multiple vessels, and that never infarcted. So you have that possibility there. So I feel you still need to rule out the actual coronary stenosis there. In fact, the example I showed you, the patient had no infarct-related LGE there. So
yeah. Something like balanced ischemia.
Yeah, or no infarction yet. They just haven't infarcted yet. They're pure hibernating, severe multivessel hibernating myocardium.
Right. We have one more question. When we use regadenoson as a stress agent, and if the stress is not adequate, how do we deal with it? Do we redose and take the images?
So I would say it's not, I would say you would approach it the same way you might do in the nuclear lab. It's hard. I mean, I'm not sure you really know when you've had an inadequate stress response without actually doing the imaging. I mean, I think I guess you're assuming that the heart rate did not go up at all for some reason, and the patient had zero symptoms. I think that's probably going to be pretty rare, right? And if it is happening, it probably they had a big cup of coffee that they didn't tell you about or something. Yeah. So I don't redose. The only time I've redosed is like if the IV contrast infiltrated right at acquisition, and so maybe I might redose and reimage at that time. But I think you have, just like in nuclear, you don't really know. You just do it and move on. You can use adenosine if they're not having any symptoms, like we do in nuclear lab, and up titrate the adenosine dose to try to get a hyperemic effect. But I think with reg, pretty much it's a one dose thing. It's very convenient though.
And what advantages cardiac MRI perfusion have when compared to CTA or plus a CT perfusion in diagnosis of epicardial disease?
That's great. So I'm going to answer this question two ways. I don't know. So I know if you have just a CTA, and then you take those patients with non-obstructed or indeterminate severity of coronary stenosis, and then you do a stress MRI, it lets you determine if those lesions are ischemic or not, and there's added prognostic value. Okay, that's just pure CTA. No one knows, I don't think, if you then take those coronary CTs and send them for CT-FFR versus stress MRI, if stress MRI adds value. No one knows that. I think that needs to be done and shown. You asked a question, the specific question as asked, lucky for me, is CT perfusion. Well, stress CT perfusion, I think, is pretty research-related technology. It's not paid for in the US, and so it makes it financially much more viable. Of course, stress CT perfusion requires an additional dose of iodinated contrast and additional radiation. So that's a balance between convenience, like the patient is there and getting all the information, versus having them come back and sending them for another test. But I think, stress CT perfusion in the US is still mostly a research related activity.
That's all the questions which we have for now. Anything else, Dr. Asher, you would like to add, or
no? I think that was great. Did I share my screen by mistake?
I guess, but
okay. Thank you very much, Amit. That was a great talk. Appreciate, again, I know how busy you are and all your other commitments, so really appreciate you taking your time to, to tell us about everything. Really appreciate it. I just wanted to say, take a minute to kind of tell the attendees about, our advanced imaging lectures. As long as the speakers give us permission, you will have these available at the Iowa ACC Advanced Imaging Lectures. Deepak or Vikram, you could put the address in the chat window. In addition, we have done lectures over the previous years, the echo board prep lectures, which were done last year. Then we have just the general cardiology board prep lectures and interventional cardiology. So if you have any time, any interest, if you are interested in knowing these topics, feel free to log in and go from there. I'm going to move on and introduce our next speaker at this time. Dr. Priya. Dr. Priya is a clinical assistant professor of radiology, pediatric body and cardiovascular and thoracic imaging at the University of Iowa. He's also the director of cardiac imaging and the medical director of the 3D lab here. He has done his training in Shimla, India, and in Delhi, India, followed by training in Boston Children's and in the Brigham and Women's Hospital at Harvard. He continued his training in at the University of Iowa and currently is a faculty. He kind of works hand in glove with me on a lot of these cases and all the time. So appreciate all his help, but also appreciate him taking his time. And he's going to be talking to us about MRI basics.
Thank you, Mahi. Thanks for the introduction. And hello, everyone. So after all the advanced topics, I'm going to talk about the basics now.
Can you try sharing your screen, maybe, sir?
Yeah, just going to. Okay. You guys see my screen?
Yes, Dr. Priya, we can see your screen.
Okay, sure. Thank you. Okay, I'll proceed. Okay. So I will be talking about the basics, and it's the when, the why, and the how. Okay. I have no disclosures. So main objectives are, I'll very briefly touch about how do we generate an MR signal, and then going over when we do it, why we do it, and how we do it in terms of sequence planning, what protocols we use. So in general, the basics of MR signal is the hydrogen spin. And why do we use hydrogen? It's because it's the most abundant in body, like it's in water, it is in fat, and 70% of body is fat, water. So the basic spin that we use is hydrogen spin in almost all the clinical MRIs that we do. So the spin is moving and it is moving around its own axis, and that's one basic thing. And then we have almost, when we put this, if I go back, okay. So when we put this spin into an external magnetic field, which is the cardiac MRI scanner, then they start precessing along the axis of the main magnetic field. So one was the spin along its own axis, and this is precession along the axis of the main magnetic field. And when the spins are precessing, they are producing two magnetizations. One is the longitudinal and one is the transverse magnetization. So this is the basics of how we are going to generate a signal. Moving forward, and the spins are, now we say about the body, we are in the external B0 field, which again is a CMR scanner. Most of the spins, they will align with the direction of the magnetic field. And some of them will be opposite to the direction of magnetic field. But the net magnetization would be in the direction of B0, which we also call Z-axis in the plane of cardiac MR. Whereas in the case of transverse magnetization, it is zero. There is no magnetization when it is only the external magnetic field. So the bottom line is that when you place the body, human body in the MRI scanner, the net magnetization is in the direction of the main magnetic field. Now, how do we generate an MR signal, and why do we need a radio frequency pulse to generate a signal? Most of the spins which are in the direction of magnetic field, as we discuss in this image, the B0 is so strong that we cannot calculate what signal is being produced by the precision of these hydrogen protons. So we need to flip them in a transverse direction so we can see what signal is being produced that will be perpendicular to the B0 field. So that's the reason we need an external RF pulse. We generate an external RF pulse using the RF transmitters, and that will cause the precision in the transverse plane, which is the XY coordinates. So this is the basic thing. Z is the B0 magnetic field. Give an RF pulse. In this case, it is a 90-degree RF pulse, and this will flip the magnetization into the XY plane. And now we will be able to generate the signal produced by this. And when the signal relaxes, now we have the RF pulse is switched off, and now the signal will go back into the Z-axis again, and the XY coordinate will lose the signal. So this is the relaxation. And we have heard about these T1 and T2 relaxation and what those are. If I move it real slow. So once the RF pulse is switched off, this is the yellow is showing the transverse magnetization. And on this axis, we will see how the recovery of longitudinal magnetization will happen. So as the recovery occurs, it takes time before the longitudinal magnetization is completely recovered. Similarly, the transverse magnetization will be losing signal, and it will be the T2 relaxation. Both of these things are occurring simultaneously, the T1 relaxation and T2, but they are independent of each other. And this is the whole basis by which we can generate a T1 weighting or a T2 weighting based upon the different T1 properties of tissues. If a tissue has a long T1, it will take long time to recover its signal compared to a tissue with a short T1 like fat. Similarly, long T2 like water will retain longer signal than short T2. And using the different echo times and TR, we can generate different weighting using T1 and T2. In general, the MR signal will depend upon how big your longitudinal magnetization is, and after you flip, what is the transverse magnetization. The long T1 tissues will recover slowly, so the signal will be low, whereas the long T2 tissues will dephase slowly, and the transverse magnetization, which is in the XY coordinate, is maintained, and the signal will be high. This is a basic thing of how we generate signal and how we manipulate our TR and TE times to produce T1 and T2 weighting. Now coming to what are the indications of cardiac MRI? We have CT, we have echo, we have nuclear, but when do we do cardiac MRI? This is a recent paper from SCMR on the clinical indications of cardiac MRI. And there are various classes on which the cardiac MRI plays an important role. And most of these also show like this is the class 1 indication for cardiac MR, especially in cases of cardiac masses, myocarditis, cardiomyopathy, pericardial disease, and coronary artery disease. CMR has a class 1 indication for evaluation of these. In addition, the recent guidelines of AHA and ACC for the evaluation of diagnosis of chest pain also places CMR as a class 1 indication for both acute and stable chest pain in patients with no known coronary artery disease. And SCMR also has this kind of a acronym on what is the advantages of cardiac MRI. And if you see, the stress CMR has a class 1 indication for patients with stable chest pain with or without coronary artery disease, and also in patients with ischemia and MINOCA. So CMR has an important role, probably as par with other modalities. Coming to the why of cardiac MRI, why do we need it and why we do it? These things, I would say, like probably are the most important reason why cardiac MRI is done. One, it has no radiation. So very important for pediatric patients and for follow-up exams. It has an excellent soft tissue contrast, which CT does not provide. It's the modality which can provide you non-contrast vascular imaging, which again, CT will not be able to provide. Flow information is another advantage which CT cannot provide. And tissue characterization. CT can help in that, but CMR has more important role compared to CT in tissue characterization. And why not? We should be aware when not to do an MR when it is unsafe. Some of the absolute contraindications, as I have mentioned here, including insulin pumps or any devices, if you have a metallic foreign body in eye, that is an absolute contraindication. And some of the cardiac stuff like abundant or fractured leads, temporary transvenous spacing leads. So these are absolutely contraindicated. Relative contraindications, cochlear implants and cerebral artery aneurysm clips. For long, they were absolutely contraindicated, but now there are some devices which are safe or conditional. So we have to make sure that these devices are safe under MRI. And most of these exams, when performed with the, when pacemaker or implants are there, 1.5 Tesla MRI is the preferred one. Coming to cardiac devices, which are safe or unsafe, in general, for pacemakers and ICDs, we say we should image at least after 6 weeks and at 1.5 Tesla. Loop recorders are conditional. They can be imaged. All the coronary artery stents, closure or occluder devices can also be safely imaged. And that also includes cardiac valves and annuloplasty rings. And temporary epicardial pacemakers can also be imaged. However, the circulatory devices, including LVAD and ECMO, they are unsafe and contraindication for MRI. So what all cardiac MRI can do? Anatomy using both black blood and bright blood images. Function information using the Cine SSFP and flash gradient echo. It can provide tissue characterization using T1 and T2 imaging, parametric mapping, and late gadolinium enhancement. And flow information using 2D and 4D phase contrast flow. Also, CMR at the minimum can help to differentiate between if the lesion is a fat, fluid, solid, or thrombus, especially when you are dealing with a suspected cardiac mass. Coming to the protocols and sequence planning, again, this is a paper from SCMR about how to plan and what sequences to be used. The how of cardiac MRI, and I'll go on this, how do we plan sequences from short axis, 4-chamber, what are the coordinates that we need to be aware of? So heart is located obliquely through the chest. And this is not like the general axial sagittal coronal that we can perform in the body when we do like a chest imaging or a body imaging. The heart has an oblique position. So we need to know what coordinates are there and how we can connect them to create the required planes in cardiac MRI. And the reason we want it to be standardized is so that we know the intermodality and inter-observer comparison can be made. Like the short axis in echo or the four chamber in echo should be similar to what cardiac MRI is, so that a comparison can be made. How do we reconstruct these planes? So this requires just thinking how the structure can be made in a 3D. If we have a line, it means we have 2 points. If we have 3 points, we can construct a triangle and so on. And if we know the coordinates that needs to be connected, then we can create the required planes. We start with a 3-plane localizer in the cardiac MRI, which is axial, sagittal, and coronal. And using the axial image, we start with a vertical long axis view. The simplest thing is to connect the mitral valve to the left ventricle apex, the center of mitral valve to LV apex, and we can create a vertical long axis view showing the left atrium and left ventricle. This view is helpful to assess the wall motion in the anterior wall and the inferior wall. This can also be planned using a stack of localizer. This is a Haste axial stack, and we can scroll through the images and find where the mitral valve is, and again connect it to the left ventricle apex. That will give us a vertical long axis view. The horizontal long axis view can be planned on the vertical long axis view by connecting the center of the mitral valve with the LV apex, and that will give us a horizontal long axis view. And using this horizontal long axis and vertical long axis view, we can plan a true short axis view going perpendicular through these sequences. And the short axis view is the most important plan or the sequence, because this helps us to calculate the ventricular function, the volumes, and also to assess the wall motion. So this is all we can do in the short axis view. We do ventricular function. We can assess for global or regional wall motion abnormalities. And using the AHA 17 heart model, we can do the motion assessment in the short axis view. And what, in addition, we are looking for, beside the qualitative, we can do the quantitative evaluation for left ventricular size in end diastole. We can measure the wall thickness in different AHA 17 heart model based upon anterior or anterior septum and the left ventricular wall thickness. And again, these measurements are done in end diastole, the wall thickness measurements. For the functional assessment, we do both for the right ventricle and left ventricle can be done in short axis. And we can do for the left ventricle, we draw an endocardial contour and epicardial contour so that we can also get the left ventricle mass. For the right ventricle, we only draw the endocardial contour. The inclusion and exclusion of papillary muscles can make a difference in your ejection fraction, and that is kind of like a site-based or institution-based if you're including or excluding. But important thing is that we need to be consistent so that the follow-up comparison can be made. SCMR also suggests that in addition to short axis, we can also use a transaxial plane for right ventricle volume measurement. Again, both end diastole and end systole. So right ventricle, we can do both transaxial and short axis, whereas for left ventricle, it is short axis view. Now to create a true 4-chamber view, we use a true short axis view and a vertical long axis view. And we connect a line which will be passing through the anterior papillary muscle and the widest angle of the right ventricle, and another line through the center of mitral valve and the LV apex. And that will give us a true 4-chamber view. For the quality check, if there is no aortic dilation, for a true 4-chamber view should not have aorta in its plane. Unless the aorta is dilated, then it may come in the plane. So in the true 4-chamber view, the qualitative analysis, again, wall motion for the septum and lateral wall. It is the best plane to evaluate for tricuspid and mitral valve, best visual depiction of all the cardiac chambers, and a comprehensive overview to compare the size of right and left chambers. Quantitatively, we can measure the size of right ventricle and left ventricle. And I would say more than the numbers, visually it is more important if the right ventricle looks bigger than left ventricle to call it dilated or not. To create a true 2-chamber view, we use the short axis and the 4-chamber view, and we use a line connecting the anterior and the inferior wall and the center of mitral valve and LV apex on the 4-chamber view to get a true 4-chamber view. And what do we use it for? It's primarily used again to see wall motion for the anterior wall and the inferior wall of the left ventricle. In the 2-chamber, we can see left atrium and left ventricle, and most of the time we can see the left atrial appendage as well. The LVOT view is constructed using the 2-chamber and short axis view. We select a slice at the base of the short axis and connect a line going through the aorta and the mitral valve, and another line in the 2-chamber view connecting the center of mitral valve and LV apex. And we get a 3-chamber view, which will be depicting left atrium, aorta and the left ventricular outflow tract, and the left ventricle. This view is important to assess the wall motion of anteroseptum and the inferolateral wall, the left ventricular outflow tract, and also to evaluate for high VSTs. And in hypertrophic cardiomyopathy patients is good for evaluating the septum. Quantitatively, we measure the left atrial size, and this is done in end systole. Whereas the wall thickness of the left ventricle is measured in end diastole. The additional views that we can acquire, the coronal LVOT view, this is performed in patients when we are evaluating the aortic valve or in aortic regurgitation to see. And this plane is created using the true LVOT view and a line passing through the long axis of the outflow tract to give a coronal left ventricular outflow tract view. This view is also important to evaluate for aortic valve motion. We can create the aortic valve to see the morphology, bicuspid or tricuspid. And again, using the LVOT views, line going perpendicular to through the sinuses of the valsalva, we can create the aortic valve view. The right ventricular outflow tract view, this is done in patients, in congenital heart disease patients or ARVD patients. We can use an axial localizer and have a line passing through the long axis of the main pulmonary artery to give a right ventricular outflow tract view. And if we need an additional view, we can also create a line passing through the long axis of the right ventricular outflow tract view to give a coronal RVOT view. The RV inflow and outflow views we can create using the line passing through the tricuspid valve and the RV apex to see the inflow and the outflow of the right ventricle. The cine view of the arch can be reconstructed using 3 points: the ascending aorta, descending aorta, and the arch. And the software allows these 3 points so that we can create an arch view in patients with anomalies of aortic arch. Again, if we are dealing with the congenital heart disease patients, we can perform branch pulmonary artery cine view. Using the axial localizer, we can plan for the main and the branch pulmonary arteries evaluation. The flow planning can be performed using the cine LVOT and the branch pulmonary arteries view to get the flow evaluation in aortic valve, pulmonary valve, and branch pulmonary arteries. And the selection of the vent in general, if there is no stenosis, it can vary from 150 to 200 centimeter per second. But in patients who have a known stenosis, we can use the echo measurements to select a venk. Some of the additional flows that can be performed, especially in patients who have mixed aortic stenosis and aortic regurgitation, and there can be some turbulence in the ascending aorta, we can perform the LVOTs flow view to look for the forward flow, and also ascending aorta, descending aorta, and SVC as a surrogate to get for the regurgitant volume in patients with aortic regurgitation. The setting of the venk is velocity encoding is important, because this is a patient of aortic stenosis, and if the venk is not set right, there will be aliasing and the measurements will be suboptimal and inaccurate. And once the venk is increased in this patient with stenosis, we can see there is aliasing is no longer seen. This is a patient with a congenital heart disease with a left to right shunt. And when we do this phase imaging, we get magnitude images, which tells us about the anatomy, and the phase images giving the flow information. And the contouring can be done on either one, magnitude and phase. But the important thing is that we should try to include only the vessel cavity. So both images should be looked for and exclude any noise outside the vessel so that the measurements are not inaccurate. Contrast enhanced or non-contrast MR angiography can be performed in patients with aortic diseases or aortopathies, and multiple measurements can be performed. The important thing for these measurements is that we do double oblique measurements. The double oblique measurement means that we have to go through both axes in different planes. For example, in this, while planning for the sinuses of Valsalva measurement, we have two views. We will be perpendicular through the sinuses in one and the other, and this will give us the most accurate view and the measurement for the vessel of interest. So that is what double oblique measurement means in two axes. In some patients, if the EKG gating is an issue, we can also perform real-time imaging, in which the entire case space can be filled in a single R2R interval. However, it has a decreased spatial and temporal resolution. In recent times, there are multiple other variants of real-time imaging that are coming using compressed sensing that may improve the image quality. So in a standard cardiac MRI sequence planning, we have a localizer, followed by a black blood imaging, bright blood imaging, and late gadolinium enhanced images. This is a standard CMR sequence. Again, starting with the localizer, we have axial, sag, and coronal that will help us plan for different short axis and long axis planes. We perform a localizer. We do both bright blood and dark blood localizer. This is a single shot true fist localizer. Also helps to know about the gross anatomy and help in further sequence planning. Black blood localizers can also be used for sequence planning, and there are different flavors of black blood imaging. One is haste imaging, which is rapid. It is a spin echo imaging. And one is what we call as a double inversion recovery or a DIR imaging. These images are inherently slow because they require additional inversion pulses. The double inversion recovery images are also performed in patients with evaluation of myocarditis to evaluate for myocardial edema. And if you suppress fat using another inversion recovery pulse, we call it triple inversion recovery pulse. These are primarily important for anatomy as well as to evaluate for myocardial edema. The bright blood sequences are important for functional evaluation and wall motion assessment. We perform them primarily on a 1.5T scanner with a balanced SSFP sequences. And we usually do a stack of short axis and few slices of the long axis, 2-chamber, 4-chamber, and 3-chamber. And we can also do aortic valve. And again, these protocols may vary based upon the institution. The flash cine is primarily kind of, I should say, a workhorse on 3 Tesla MRI. And the reason for that is that the SSFP sequences, which are very high contrast, but they have susceptibility artifact issues. And those are very common on the 3 Tesla MRI scanner or in patients who have some metallic devices. So in those patients, we can perform a flash sequence. It has a low signal, but it is free of those susceptibility artifacts that we see on SSFP sequences. The other difference is SSFP gives a T2 T1 weighting and the flash gives T1 weighting. At present, most of the 1.5 Tesla scanners, we only do SSFP imaging unless there is a susceptibility artifact. And 3 Tesla MRI, we do use SSFP imaging, but because of the artifacts, flash imaging plays an important role on 3 Tesla CMRI. Some advanced thing that we can use on these cine images is a feature tracking, which is to evaluate for strain. It does not require any change in the cine imaging that we do. It is a routine cine imaging, and we can use different available softwares to calculate circumferential longitudinal strains in short axis and long axis. These cine images are followed with the post-contrast imaging, and we can do it with high TI and low TI. The high TI imaging is done at 600, and that is to evaluate for thrombus. And the reason is that at high TI, we expect things that have contrast to retain contrast, whereas thrombus will not retain contrast. The post-contrast imaging, the late gadolinium enhancement, the first step is to acquire a TI scout. And why do we need a TI scout is to see the time, the inversion time where myocardium is black, or we call it the null time of myocardium, so that when the late gadolinium enhanced imaging are done, the thing which will show enhancement will be counted as abnormal. So using the TI scout, we can calculate the inversion or the null time of the myocardium. And these sequences can be done both in single shot and breath held. And we can do, again, stacks of short axis and long axis view. Again, that depends upon the institution. And this can be done with a 2D true FISP or a GRE sequence with inversion recovery prep. And we can also do breath held, or we call them as segmented late gadolinium enhanced imaging. They have a high signal to noise ratio, but they take additional time. Again, we can do them in short axis stack and in different long axis view. Traditionally, the acquisition is done every other beat for the signal to recover. However, in patients with bradycardia, we may do every beat, and in tachycardia, we can do every third beat for the signal to recover. The LGE imaging, if the scanner provides, there is an additional sequence, which is the PSIR, in addition to the MAG, which is the magnitude. PSIR stands for phase sensitive inversion recovery imaging. And the advantage of this is that if the TI time is not selected properly, the phase sensitive images can provide kind of as a fallback plan that even if the TI time is selected is not right, the myocardium is still nulled black. So if the scanner has PSIR images, we should have a look at that also if the TI time is not selected properly. The other thing to comment upon when we see the late gadolinium enhanced images and we see some enhancement, what is the pattern of enhancement? Is it subendocardial? Is it mid-wall? Is it subepicardial or transmural? Since there would be different connotations and different etiologies that are linked to different patterns of disease. This is a recent sequence, which is known as the flow-independent LGE or FIDL. Again, it is not very widely available, but what it does is that in some patients, especially if it is a subendocardial enhancement, since the blood is also bright, it is difficult to evaluate the signal in the subendocardium. But if using this sequence, the blood pool is dark, so we can very clearly see the subendocardial enhancement. This is known as flow-independent late gadolinium enhancement. These additional sequences may or may not be done, and that depends upon the indication of the cardiac MRI. T1 mapping is recently commonly used, especially for evaluation in patients of cardiomyopathy and myocarditis. We can plan these sequences in short axis view. We do it over in 3 slices at base, mid, and apex. You can also do it in 4 chamber. We can perform native T1 mapping, which is pre-contrast. The post-contrast T1 mapping, if done, it is done after 10 to 30 minutes of contrast administration. And if both are done, we can generate extracellular volume fraction. Similarly, we can do a T2 mapping, again, at 3 slices, base, mid, and apex, and we can see the analysis. And again, the basis of T1 and T2 mapping is the same recovery of, as we discussed before, the T1 and T2 relaxation. The signal recovery is what we are using for the pixel-wise map generation. As per SCMR, for the global assessment and diffuse disease, either you're doing a T1 mapping, T2 mapping, or T2 star mapping, we draw a contour in the septum, and that is used a single ROI in the septum, in the mid cavity, using a short axis plane to know the global value of the T1, T2, or T2 star. If focal disease is there, or visually we are seeing edema, we can use additional ROIs there. Hint is that we should avoid very small ROIs, less than 20 pixels, and we should draw ROIs on grayscale rather than on the colored mapping. This is as per SCMR. And this is just how the T1 mapping and the ECVs can be used in various diseases. Like in myocarditis, the native T1 can be increased. Similarly in amyloid, and condition which can cause decreased T1 can be Fabry's disease or iron deposition or even fat deposition. Similarly, we can see the values of T2 increase in patients with myocarditis, signifying presence of myocardial edema. So parametric mapping, it may or may not be done in a routine protocol, but it is useful in patients when you are suspecting any myocardial disease. And its use has been shown in patients with amyloidosis, Fabry's disease, myocarditis, and iron overload. Stress cardiac MRI, we already listened to the lecture, but the stress and the rest perfusion can also be performed based upon the indication. And we plan 3 short axis slices and 1 4-chamber slice. And between the stress and rest perfusion, there should be a 10-minute time before you do the contrast. And between the resting perfusion and the late gadolinium enhancement, a 5-minute time is suggested, again, as per the SCMR protocols. We all kind of think cardiac MRI as a very long protocol, but there is an abbreviated protocol that SCMR suggests, which can be performed for a variety of indications that will only take 30 minutes to complete a cardiac MR. And especially, it can be performed when we are only evaluating for the ventricular function and ejection fraction to look for scar or viability, and also in patients looking for any mitral regurgitation or inflammation or ischemic injury. And on these, if we add T1 and T2 mapping, there will be a slight increase, but most of these indications can be done only in a 30-minute cardiac MR protocol as well. To summarize, these cardiac imaging planes and sequences are standardized. We need to know the coordinates of how we should plan these sequences. Quality check is important so that we can repeat the imaging if required. We can modify the sequences and protocol as per the indication. And we should also be aware about the MR safety so that we know when and when not to do the cardiac MRI. Thank you.
Thank you, Dr. Priya. Really appreciate your talk. We have a couple of questions in the chat box. The first one is, most of them are from TZ. So the first question is, when do we use bright blood and when do we use a dark blood?
Sure. So dark blood imaging is primarily used for anatomy, and the different flavors of this dark blood imaging are there, and I think that can explain when to use that. First is HASTE. HASTE stands for like a half Fourier single shot turbo spin echo, and what does that mean is that we are only acquiring half of the K space. So it is a very rapid thing when you're just trying to see what the basic anatomy or morphology is. So most of the time when we do this HASTE, we do use it as a localizer image and use it to plan further sequences. So that's the first basic use of the black blood HASTE. The other flavor of black blood imaging is a double inversion or a triple inversion recovery images. And these are used both as T1 and T2 in patients with myocardial edema. We can evaluate if there is any signal intensity increase in the myocardium. And the other important use, which I think is the more important use, is in evaluation of cardiac mass. We can do a T1 imaging with and without fat sat, and T2 imaging with fat sat. And those are done using a black blood imaging or a double inversion recovery imaging. So primarily, again, it is the anatomy or the morphology of the myocardium, the cardiac mass, or in general. The bright blood imaging are primarily used for function. Again, two flavors. One is the SSFP, which is a balanced SSFP. Another is the flash. Both are gradient echo images, and their use is to see the cine, the motion, or the function. The different type of this bright blood imaging is a single shot through FISP imaging, which we can use as a localizer image that I show also. Again, that can use for anatomy. But in a simple way, bright blood imaging is all about function and wall motion, and black blood imaging is for anatomy, cardiac mass evaluation, and myocardial in patients with myocarditis that can be used.
And the next question is, are normal value measurements similar to echo?
Normal values of
on the cardiac MRI, like the volume, function, thickness, I guess the question is, are they same as what we get from echocardiogram?
So I don't usually do echo, but mostly these are kind of in sync with that. I think one thing I can say is that for the right ventricle, cardiac MRI is more accurate and more reproducible than echo. For left ventricle, I would say probably both do the same. But again, I would let echo people talk about this more if there is like comparison thing. But definitely for right ventricle, it is the cardiac MRI.
Right. I think cardiac MRI is kind of a gold standard when it comes to like measurements, and then also depends like how good images you have. So
yeah,
talk about it basically on our echo boot camp, how comparable it is with the cardiac MRI. I think the next question is, who is usually interpreting the extracardiac findings in the centers in United States? So is it cardiology or radiology? I think it's a center specific, at least here in Melbourne, we have radiology reading all the cardiac MRIs, but I don't know what's your experience at the university.
So at University of Iowa, it depends like who is reading at that kind of like in the coverage time. Like if I'm reading, I do both cardiac and extracardiac. But if a cardiologist is reading, they will be providing interpretation of the cardiac MRI. And then the image goes to radiologist for reading of the extracardiac stuff. It kind of varies like who is covering the cardiac MRI that day.
And is quantification of stenosis and approximation?
Stenosis and approximation.
And approximation, right? I'm not sure if I quite got that.
If it is about the
degree of stenosis,
like the phase contrast studies to evaluate like for aortic stenosis, I think we do. If the question is related to that, we do provide the P gradient, but again, there are like so many variables in that, especially the direction of the jet. If you are not perpendicular to that, I think those caveats are there. And when we provide these numbers, we do mention that I think we have to like correlate with echo as well, just to be sure that we are not going too off in terms of regurgitation. And I think MRI plays very important role, especially for the regurgitation component. For the stenosis component, it's kind of, I'm not sure it is, in my experience, I think it can vary, especially the stenosis component. So I always compare with echocardiogram for that.
And if there is time to explain what K-space is.
Oh, I'm sorry. K-space is the raw data of the MRI. So all the images that are required first they are acquired in the case space. And when we do the image transform, which is known as the Fourier transform. Again, these all things happen in the background. And then we get the MRI image. So that's the simplest answer. Like, it is the raw data of the MRI that is converted into the image data for our visual assessment.
And why don't we just do PSR only? Why do we also do MAG?
Well, first thing is that not all scanners actually have PSIR images. So it is the other way. Some vendors only have the MAG images. They actually don't have PSIR images. Traditionally, we use both MAG and PSIR. The other thing that is mentioned for PSIR is that if the TI time selected is accurate, the PSIR images also have like more accurate interpretation. The PSIR is a fallback plan if the TI time is marginally kind of not right, like rather than selecting an inversion time of 250, I select maybe 230. But like if you are at 100 or 300, there is a big difference. The PSIR may not help in that as well. So I usually see both MAG and PSIR just to make sure that I'm not calling anything artifactual thing as real.
Great. I think there were some couple of excellent questions. We don't have any more questions as of now. I'm not sure if you have any other questions, Dr. Ashwath.
Thank you very much, sir. That was very informative. So I think just one of the comments about, who kind of overreads the scans. I think it depends on the center for the most part from my experience. I think there's a few centers where the cardiologists kind of overread everything, mostly for MRI, maybe not as much for CT. But most centers, I think there's co-reading of the extracardiac findings and stuff. And sir, if you have a few minutes, would you be able to comment on like the common artifacts that we see on MRI?
I would have. I don't have any slides prepared for that. It's hard to put together like just now.
Yeah.
Sorry.
No worries, no worries. Well, thank you very much. Appreciate you doing this talk. It was very helpful and very informative. And again, thank you very much for your time on this beautiful Saturday.
Yeah, thanks, Mai. Yeah, thank you. Thanks, everyone.
So I guess we have a couple of minutes before we have our next speaker, Dr. Hayes, who would like to join. I'm not sure if we want to take a small break. We'll keep the chat on. Then as soon as we have Dr. Hayes on, we can resume our lecture series. Do you have any other thoughts, Dr. Ashwath?
Yeah, I messaged Dr. Hayes. I think he should be joining in momentarily. But again, as a reminder to everybody, these lectures we are doing, this is the third year that we're doing these lectures. If you have any thoughts or any comments or anything, please feel free to let us know. I had a lot of people come by at National ACC and kind of introduce, to me and to our other leaders, and it's very gratifying to see that. So if you see us anywhere, feel free to please reach out to us. Again, along with me today is Vikram, Deepak, our FIT co-chairs, and Anthony and Michael, our social media representatives. These lectures would not have been possible without all their help. So a big shout out to everybody here. I'll go ahead and introduce our next speaker. I think she should be joining momentarily. Dr. Allison Hayes. Dr. Hayes is the medical director of echo programs at Johns Hopkins Hospital. She's also an assistant professor at Johns Hopkins University School of Medicine. She graduated from Stanford University with degrees in biology and English. She received her medical training at the Columbia University College of Physicians and Surgeons and did her residency at New York Presbyterian Hospital at Columbia. Dr. Hayes pursued cardiology fellowships at NYU Medical Center and at the Hopkins University School of Medicine. She studies ways to use non-invasive imaging to detect cardiovascular disease. She has advanced multimodality imaging training from Hopkins and attends in the adult echo lab at Hopkins. In terms of research, she uses cardiac MRI as a tool to study coronary and systemic endothelial function. She should be joining us momentarily. So maybe a 5-minute break, like Deepak said.
Dr. Arshad for introduction, and I'm just waiting to have Dr. Hayes back on. So we'll just keep the chat box open. If anybody has any questions, we can discuss, or we can just wait, and I'll keep you guys posted. Thank you.
For those who are kind of leaving and joining, we're just waiting for Dr. Hayes to join. Should be just a few minutes. Thank you for your patience. It's not there. Dr. Hayes just joined, and she will be starting the talk shortly. Again, she is the Echo Lab Director at Hopkins University, and we thank her for doing this talk with us.
Thank you. Should I go ahead and share right now? Can you hear me okay?
Yes.
Yes,
Yes.
Great, sorry.
Yeah, we can hear you. And I just kind of introduced you to the audience as we were waiting. So please go ahead. Thank you.
Okay, wonderful. Thank you so much, Mahi, for the invite. And it's a pleasure to be here with you today for the talk on the ACC. I'm just going to open up my slide. Okay, so basically what I'm going to go into today is imaging evaluation with more of a focus on CMR. I will introduce a little bit of echo just because, to be honest, that's usually the first line of evaluation for these types of cardiomyopathies. But I'll be focusing on ARVC as well as a couple of infiltrative cardiomyopathies. And I'll focus on the most common ones, which is cardiac amyloidosis and cardiac sarcoidosis. Before I start, I wanted to give a little bit of background on the utility of CMR, and you've heard that today in the prior talks. But basically, something that's changed, especially in the last 5 years, is the more highly featured utility of CMR in the clinical evaluation of cardiomyopathies, particularly in the European guidelines. And that's gaining traction in the United States too, although I would have to say, just from clinical experience, not everyone with cardiomyopathy is getting a CMR, but I believe that everybody should, because it's very useful for the clinical diagnostic workup as well as prognosis. So when someone has a suspected non-ischemic cardiomyopathy, oftentimes we perform CMR after echo is performed, and we look at a couple of features. First, Cine CMR to look at LV and RV structure and function. Newer techniques, which I'm sure were mentioned in prior talks, are T1, T2 mapping, T1 for fibrosis, that's diffuse, and then T2 mapping mainly for inflammation and edema. And that's been particularly prominent in the last couple of years with COVID. So there's a lot of interest in T1, T2 mapping. It's now rolled out in most clinical workplaces. It's still a somewhat specialized technique, so you won't see it at every institution, but it's gaining a lot of traction for the evaluation of fibrosis and edema. There's also T2 star mapping, which is very specialized, but very helpful and specific for iron overload in the heart. So I'll talk about that later as well. So once you have the diagnosis or something that's suggested with CMR, then you can go on to do a deeper dive, start goal-directed medical therapy. And then when do you perform repeat CMRs? So if someone, no matter if they have an inflammatory cardiomyopathy, like myocarditis, genetic or dilated, a lot of times patients will experience a clinical deterioration, and that may come in the form of increased arrhythmias or heart failure. So at that point, a CMR may be useful to see the extent of late gadolinium enhancement, or LGE, to define the myocardial damage burden, then to reevaluate using Cine CMR, LV structure and function, and then perform follow-up T1 mapping to gauge whether fibrosis is worse. So that's typically how CMR is used for follow-up if a patient experiences clinical deterioration with a known cardiomyopathy. The other way CMR is used is to gauge treatment response. So we don't really use LGE as much to gauge treatment response. We're more focused on Cine CMR to look at structure function of the LV-RV. You can also use T1, T2 mapping and extracellular volume fraction, which I'll discuss briefly, as well as T2 star mapping for iron overload to gauge response to therapy. And a lot of what's happened in the last couple of years, particularly with the European Society of Cardiology, is kind of moving towards more novel imaging techniques. So in terms of echo or even CMR, we've moved from ejection fraction, which is still incredibly important, to looking at more subtle indices of myocardial dysfunction, such as strain. Echo, there's also a move towards 3D imaging, which isn't available in most centers, but it does provide accurate volumetric quantification of both the LV and RV if the image quality is good enough. So for our lab, we're able to do some volumetrics, but because of the increased cost and the software required, it's still not very widespread. But that's something we're moving in the direction in, is to teach sonographers how to do 3D echo, because overall you can have a more quantifiable and reproducible method for gauging LVEF, RVEF, and volumes. In addition, we've moved from rest to stress assessment of LV function, and then from late gadolinium enhancement to T1, T2 mapping, which aren't replacing that, but they provide very useful and complementary information to LGE. In addition, we're also moving away from invasive coronary anatomy characterization to non-invasive, so CT perfusion, as well as MR perfusion. And these are kind of newer developments which are being stressed. And some of the benefits of a CMR for the evaluation of cardiomyopathy are, I would say, manifold, but some of them are that you have a more detailed characterization, particularly of the tissue. So instead of with an echo, you're getting hemodynamics, valvular assessment, cardiac structure and function. With CMR, you're additionally obtaining myocardial edema assessment, scar, and fibrosis. And so these are some of the basic sequences, which I'm sure you talked about earlier today. And I would just want to illustrate just one of the things that is commonly done for a cardiomyopathy workup with CMR is T2weighted stir imaging. And that's to assess the myocardial free water content. And that results in an image. And basically what it tells you is the regional distribution of inflammation. Whereas if you look at it, if you acquire a T2 map or a T1 map, it basically will provide you a number which reflects either fibrosis, and usually you select several regions of interest. So it's less of a visual than a number. And a T2 map, it's the approach is similar. You kind of have circle different regions of interest, and then you average and to come up with a T2 time. And basically what most centers do is, because the T1 and T2 values are very variable amongst different scanners, including brands and field strengths, it's very important for each institution to develop their normal range. So that's typically what's done. So every institution will scan a bunch of normal values and provide like means and standard deviation. So for what is the T1 expected on this particular scanner at 1.5 T, the same will be done for T2. And that's very important because there's a lot of variability out there. And so this just image just illustrates the multifaceted role of CMR. So this is an example of LGE and showing late gadolinium enhancement in the mid myocardium, suggestive of endocarditis. This is what I was talking about before, T2 stir imaging, showing these bright areas are regional edema in the same distribution as LGE. And then you can also see different views. So 4-chamber, another short axis of a different patient showing LGE that's more transmural. And then T1 and T2 maps as well. This also shows the benefit of looking at strain, whether it be by echo or CMR. And basically what this shows is global circumferential strain on one axis and global longitudinal strain on the other axis. And even though EF, as you know, may be preserved, you can have altered contraction with preserved EF. In the cases, a lot of times with HFpEF, amyloidosis, and other infiltrative cardiomyopathies, where the first thing to be reduced is the GLS. Oftentimes the GCS is later to go, and that could be normal up until when you start to experience a reduction of EF. So for here, you have reduced contraction reflected by all three metrics, EF, GLS, GCS. And I would say the most important kind of metric that we look at if feature tracking strain is done is global longitudinal strain, similar to echo. And this just shows progressively reduced strain depending on the level of heart failure. So the top is healthy, and then they kind of go with the stages of heart failure: at risk, pre-heart failure, and heart failure, where strain gets progressively reduced. And so I'll talk a little bit about the different strain techniques too, but just briefly to reiterate the kind of conventional cardiac MRI techniques, SSFP, which results in a cine moving image, and that's kind of the stock CMR function that like every patient will get when they undergo CMR. Then more specific indices that we're interested in, oftentimes LGE, inflammation, which can also help with assessment of the pericardium to see if there's inflammation of the pericardium. And then more specialized analyses include CMR for ischemia perfusion and wall motion analysis. So that can be done either using adenosine or dobutamine, as well as quantification of LGE. More novel CMR parameters include strain and strain rate, mostly focused on longitudinal circumferential. And I would say one of the major developments in CMR over the last 5 to 6 years is it used to be that you had to use special sequences called SENC and tagging to look at strain of the LV and RV. And they're still used, but mostly for research purposes. And that usually involves asking the patient, after you finish all your cine sequences, to then do a bunch of breath holds, repeat short axis, and do these special tagging sequences. So it does prolong the scan a lot. But in the last 5 years, they developed sort of post-processing techniques using feature tracking. So as long as cine SSFP sequences are acquired on MRI, then you can go back and either the technologist or someone else can perform feature tracking analysis, provided you have the right software like Circle, and then derive RV free wall strain, LV strain, and LA strain. So some labs are doing this now. In addition, I already mentioned the assessment for diffuse myocardial fibrosis, as well as collagen volume fraction. And then some other places will also do vascular function analyses using pulse wave velocity, as well as wall shear stress. That's particularly important for the aorta. And this is an example of native T1 mapping, which has become very important in clinical CMR. So this is an example of a normal person, and it really has to do with the gradations that are used at the local institution. But here the normal range is sort of is basically green. This is a person with HCM. And then basically what you need to know is that most disease processes cause T1 to go up. I would say the vast majority: amyloidosis, sarcoidosis, even post-MI. So here you can see two examples of amyloidosis where you see a little red, and that reflects an elevated T1 value. And there are really only two processes that cause the T1 to go down. So here in the blue range, it means reduced T1, and that's Fabry's disease and iron overload. And those are very distinct. And those are the only disease processes known to consistently reduce T1 value. So this also just shows different examples, which I'll get into when we go into the different disease states, but this is a normal myocardium. This is LGE, T2 stir, and then T1 map, and then someone with amyloidosis. So the first thing you'll notice here, and I'll kind of go into more details later on, is that the contrast between the myocardium and the blood pool is reduced in amyloidosis. And so that's one of the signature features of amyloidosis when someone's performing a CMR exam, is that there's difficulty nulling the myocardium. And what that means, nulling the myocardium, means manipulating the sequence to make the myocardium black. So here you can see this myocardium here is nulled. That means it's black, has zero signal. But in amyloidosis, they tried to null it, but the blood pool is actually black and the myocardium is kind of gray and there's reduced contrast. So once the technologist sees that, then they have to do special sequences to determine the optimal inversion time to then optimize the sequence later. So I'll show you how that's done. But that's kind of a signature trademark for amyloidosis, which I think is really interesting and important to know. In acute myocarditis, a lot of times I would say the signature trademark for this is mid-myocardial enhancement. It's a little bit difficult to make out here, but it's inferolateral. And then you can see some edema here. And you can see that as localized elevation in T1. In addition to T1, which is native, doesn't require contrast, is extracellular volume mapping. And this plays an important role in prognosis in a variety of disease states, whether it be non-ischemic dilated cardiomyopathy, amyloidosis, sarcoidosis. So it helps to not only identify if there's infiltrative heart disease, but also has strong prognostic value. So for ECV, extracellular volume fraction, it's basically the formula, and it incorporates both pre and post contrast images. So you do need LGE in order to create an extracellular volume map, which is done automatically. And basically it also comes up with a number. The increased ECV reflects increased edema and infiltration, and is particularly useful in cardiac amyloidosis. So here you can see that those patients who have the highest ECV, greater than 28.6%, had the worst event-free survival over several years. And so one of the important things when you're considering referring someone for a CMR or interpreting is just to think about what are the consequences. Does this actually have an impact on clinical decision-making? Because that's the most important thing. And so people have actually studied this, and there is a working group in EuroCMR that looked at the European Cardiovascular MR Registry, and they basically found that the utility of CMR on cardiomyopathy impacted patient management 61% of the time. So it is a good diagnostic test. And they basically resulted in either a new diagnosis, such as amyloid, sarcoid, dilated cardiomyopathy, myocarditis, post-MI, or had significant therapeutic consequences. So that's important to note. And so some of the objectives I want to talk about today are review the utility and prognostic value of echo CMR on the treatment of cardiac sarcoidosis, as well as amyloidosis and ARVC. And so in general, I'll start off with the infiltrative cardiomyopathies and then move to ARVC, which is a genetic cardiomyopathy, but they're characterized by deposition of abnormal substances, particularly protein or cells within the heart that can cause myocardial damage and dysfunction. And the diagnosis is often requires a high degree of suspicion, and imaging plays a very critical role, as well as laboratory diagnosis. And a lot of times they represent the cardiac manifestation of various systemic diseases. So these are the various infiltrative cardiomyopathies. Just for time's sake, I'm going to stick to the top two because those are the most common, and I would say underdiagnosed areas in which also CMR plays a critical role in the diagnostic workup pathway. So for sarcoidosis, it's as you know, a multi-system cardiac disorder resulting in deposition of non-caseated granulomas. And this disease often occurs between the ages of 25 to 60. It's increasing in incidence overall, and a lot of times it goes clinically undetected. And so clinically overt cardiac disease is not that common. It only occurs in about 5% of sarcoidosis patients. However, clinically silent cardiac sarcoidosis or CS that's undetected can happen in about 25% of patients. And this was based on prior autopsy data as well as CMR data, and like all comers with sarcoidosis. So 25% can have cardiac involvement. And basically because of improvements in cardiac imaging and awareness, that's led to increased diagnosis. And so the way that cardiac sarcoidosis presents typically can be a variety of arrhythmias such as heart block, ventricular arrhythmias, heart failure, but initially it tends to involve the basal septum. And so when that happens, it's usually clinically silent, but if inflammation occurs and progresses and involves more areas of the septum, this can manifest as heart block. And patients who are presenting with CS with heart block have particularly bad prognosis and are less likely to respond to therapy. And that's been shown in several clinical studies. And basically some of the clinical manifestations as well, because of the patchy involvement, involve having VT. So this is a more advanced cardiac sarcoidosis. And basically it leads to patchiness of different areas of the septum and free wall, which can then result in ventricular tachycardia and heart block. And some of the clues for cardiac sarcoidosis include abnormal myocardial perfusion, and that can be assessed with a variety of imaging techniques. It could be nuclear study, CMR, it could be CT, but if you see a discordance between abnormal perfusion and in the setting of normal coronaries, you should always consider that there may be cardiac sarcoidosis and assess further. And so basically another clue that you can detect on echo is regional wall motion abnormalities that are completely unexplained by the presence of CAD. And so that can be assessed with for stress testing, CT, cath, but it's also important for patients with suspected CS to undergo a very thorough CAD workup. And so another way of presenting is unexplained pericardial effusion. And then clinically, we have unexplained syncope or high burden of PVCs. So it always should be considered middle-aged people presenting with VT for the first time, unexplained syncope, or even atrial arrhythmias, which are relatively common. And so our diagnostic tools as cardiologists include, of course, electrocardiogram. However, the clinical yield of uncovering a diagnosis is very low for cardiac sarcoidosis. So it's rarely abnormal in clinically silent CS. And EKG abnormalities can be present, such as right bundle branch block, ST wave changes, bifascicular block, but these are very nonspecific. And so the utility of the EKG will help if someone's presenting with heart block or atrial arrhythmias or VT, but just because an EKG is normal and someone's suspected CS doesn't mean they don't have it. It's just not very sensitive. And so echo also is useful, but not very sensitive. And so there's no single pathognomonic echo abnormality that's specific enough to clinch the diagnosis of CS. So some of the more non-specific findings include regional wall motion abnormalities, LV, RV systolic or diastolic function, and ventricular wall thickening. I would say the most probably kind of interesting and maybe more signature finding would be infrabasal septal aneurysm with akinesis or hypokinesis, because they do, cardiac sarcoidosis does have a predilection for the basal septum. So sometimes you'll see people presenting with kind of aneurysmal basal septums with severe hypokinesis to akinesis, and that should lead you to think about CS. In general, this shows an example of that. So this is a normal, someone with early CS that's not detected on echo, but then later on the disease, they can develop focal aneurysm. So here you can see kind of outpouching and the short axis view and the parasternal long, where the also like you can kind of see a step up in the septum here where it's slightly thinner and hypokinetic. And then once CS is late stage, it can become like any dilated cardiomyopathy, like burnt out. The other diagnostic tool, which I think is extremely useful, is CMR. And you can also sort of see a progression and think of that way. But basically, here's a normal patient, someone with a very focal LGE, just isolated in the inferior wall. And they also don't follow a distribution of cardiac coronary ischemia. So that's important to know. As it gets more involved in the heart, you can see multifocal LGE areas that are patchy. And then later on, if you see transmural involvement, that's a very bad sign. That's very advanced CS. And so cardiac MRI is one of the most specific and sensitive imaging modalities to detect CS, especially in comparison to Holter, EKG, echo. And LGE is a very important prognostic marker, in addition to basically any non-ischemic dilated cardiomyopathy. And they predict cardiac events, including mortality, cardiac transplant, need for heart failure hospitalization. And there's no single biomarker that's been identified to be specific enough for the diagnosis and management. So you can get a troponin BNP, but they're not going to be sensitive or specific. And so given the focal nature of cardiac sarcoidosis, unfortunately, the sensitivity of endomyocardial biopsy is also low. And so one of the nice things about CMR is that you can detect the presence of edema using the T2 techniques that I mentioned. You can either do T2 stir, visualize where the edema is, but it's hard to quantify, or T2 mapping. And so it has a very good positive predictive value, but the negative predictive value is low. So that's something important to keep in mind. So just because you don't see any abnormalities in T2 imaging or mapping, or even in LGE, it doesn't mean they don't have cardiac sarcoidosis. And this is really important because a lot of times people present for the first time with sudden cardiac death, and arrhythmias account for 30 to 65% of deaths in CS. So it's just very important to be aware of that and to initiate appropriate monitoring clinically. And so guidelines suggest ICD for primary prevention for people with definite cardiac CS if the EF is less than 35%, or for symptomatology like abrupt onset syncope or evidence of scar. And in general, some of the guidelines and clinicians use a threshold value for LGE. And that's something that's sometimes difficult to get at depending on where you're obtaining the CMRs. I think if it's at a specialized academic center, you could probably get quantification by and what they usually do is they'll give a percentage of the LV mass. So LV mass is easy to determine on CMR, but what you really want to know is what's the percentage of LGE in the LV. And so the cutoff that is oftentimes used is greater than 5.7%, and that's considered significant. And so some of the guiding principles of CS in general are to always strive to make a tissue diagnosis when possible, and then to always consider the risk of sudden cardiac death at all times with Holters and PET scans. To also make sure you obtain a very good coronary artery disease workup by coronary angiography or CT. And then it's also important to assess the total burden of disease since it's a multi-system disorder. And it's very important to have multidisciplinary engagement with rheumatology, pulm, and other areas. And so this is a really nice review article from Ryan Blankstein and his group, basically showing the different gradations of probability of CS. So here we have no cardiac sarcoidosis and the findings typical on MRI and PET. So if there's low suspicion or none, then you basically won't see any LGE on MRI. This is just a normal MRI exam. And then on PET scanning, you're looking for two things. You're looking for FDG uptake and perfusion defects. And so if the likelihood is low, you'll find neither. So basically, these are all negative. If you have possible CS, that's basically, I would say, the majority of patients, you may see a focal area of LGE, as you can see in this picture here in the inferior wall. And then you may not see any FDG uptake, but you might see a random small perfusion defect, and it might be in the same area as the LGE. When you have someone with probable CS, then you might start to see patchy focal, a multifocal involvement of LGEs, kind of like small areas lighting up on LGE that don't follow a coronary distribution. So here's a nice cartoon of that. And then on PET, you may see focal or diffuse FGE uptake, which is associated with resting perfusion imaging. Or you could see multiple non-contiguous areas of scar with no FGG uptake at all. And then when you have highly probable CS, like let's just say you're unable to get a tissue diagnosis, but you obtained imaging with MRI and PET, then basically the CMR most commonly will show multifocal LGE in a pattern that's strongly suggestive of CS in the absence of an alternate diagnosis. And then on PET scan, you'll see multiple areas of focal FDG as well as extracardiac FDG uptake too. And you also might see focal areas of both FDG uptake as well as perfusion defects as well. And so this is a nice longitudinal study that shows survival free of death or VT in patients who have normal perfusion and FDG, that's up here in green. And then the worst case scenario in which you have both abnormal perfusion and FDG uptake, those patients have the worst event-free survival. If you just have one or the other, either abnormal perfusion or FDG, then you're in the intermediate risk zone. And so a lot of times the approach to the patient will use combined CMR and PET. And basically the main point of this diagram is showing that if you have negative LGE, that's very helpful. But if you still have a high clinical suspicion, you should still move on to FDG PET. And once you do FDG PET, you'll either see abnormal FDG uptake, which is suggestive of myocardial inflammation, in which case you should refer and consider for immunosuppressive therapy, or you'll see nothing. You'll see no FDG uptake, and it might be that this represents scar from burnout of cardiac sarcoidosis, in which case it's very unlikely that immunosuppressive therapy will help. And so that's not indicated. If you do see LGE, and especially if it's significant amount of LGE, then you should consider ICD implantation. And so the cornerstone of treatment is immunosuppression, management of heart failure. And these are some clinical situations in which immunosuppression should be considered. And primarily, like once you start having evidence of advanced heart block, Mobitz type 2 or third degree, you should consider that, as well as frequent ventricular ectopy or sustained ventricular arrhythmias. Especially also if you see evidence of LV dysfunction in the setting of myocardial inflammation, either detected on PET or CMR, that's also indication for immunosuppressive therapy. And I won't get too much into PET, but basically it's used as a really helpful tool to monitor response to therapy. So once you start someone on immunosuppressive therapy, you'll want to follow them over time. And most often what's used, especially here at Hopkins, are echo and PET. We're not really using CMR to follow people over time. It's less useful than performing serial echoes and PET scan, where you can really see the extent of inflammation and gauge the response to immunosuppression. CMR also is challenging in follow-up, especially if patients do end up obtaining an ICD, although it's definitely possible. It's just it's just a little bit more difficult and requires more resources to be able to scan with an ICD in place. However, if the patient does develop new ventricular arrhythmias or a lot of firing of the ICDs, for instance, then you'd want to get another CMR. So the role of CMR, it's particularly important in both amyloidosis as well as sarcoidosis. And you can kind of see two pathways. We already discussed its role in cardiac sarcoidosis, that you still need to move to PET if it's inconclusive or positive, or if there's a high clinical suspicion on CMR. And for amyloidosis, I'll talk about in a minute, but it's also incredibly useful as well for the detection and follow-up. And so basically, in conclusion, for cardiac sarcoidosis, thanks to improvements in imaging with mapping techniques and scar quantification, this has led to increasing detection of cardiac sarcoidosis, which previously was felt to be extremely rare and hard to detect. CS patients will typically present commonly with arrhythmias, and then CMR is currently the best diagnostic screening test for those with suspected CS. In addition, just to reiterate, immunosuppression with steroids remains the leading treatment strategy, although honestly, there's not incredibly robust data to support this. And so when I went to the recent ACC meeting in Washington, DC, I went to a cardiac sarcoidosis panel, and there is an active multi-center international trial that's underway right now to look at different dosing strategies of steroids, which is definitely very much needed. And I think the reason this hasn't been done yet is just because these patients are fairly rare and it's relatively difficult to diagnose. So it's good that it's a multi-center trial to be able to recruit enough patients for this. And the prognosis, I would say one of the knowledge gaps in this area is that what is the prognosis of clinically silent cardiac sarcoidosis? It's not very well known. And then finally, the last point is that the presence of LGE on CMR and inflammation on PET are risk factors for heart failure and as well as adverse cardiovascular events, mainly arrhythmias. So now I'll move to amyloidosis, which is also a very interesting disorder that's also underdiagnosed and also has delayed presentation and detection. It's probably much more common than we even know. But it typically results from a systemic process that results in extracellular deposition of abnormal insoluble fibrils, so beta amyloid fibrils, and they're derived from a variety of serum proteins, and it's also a multi-system disorder. And so we mostly are focused on cardiovascular. Amyloidosis can present as heart block, ventricular arrhythmias, a lot of times heart failure, those would be the most common. But you also have a lot of CNS manifestations, ortho, autonomic neuropathies. Oftentimes people have carpal tunnel syndrome as well. So it is a multi-system disorder. So it's important to have multidisciplinary engagement. And there's some, I thought this was a really nice review article. This is kind of illustrating some of the red flags for cardiac amyloidosis, like when should you suspect it if you're seeing patients in general cardiology clinic. So as you know, if there's a discrepancy between the voltage on the EKG, so you see low voltage, but you see either a thick heart or someone with hypertension, that should lead you to suspect this. Typically, if you see thickening of the septal or posterior wall over 1.2 centimeters, but you see low voltage on the EKG, that should lead you to think about cardiac amyloidosis. In addition, if you see thickening, not only in the LV, but also the RV free wall, as well as the valves, particularly the aortic valve, that's considered a red flag sign. Clinically, if you see someone who has intolerance to beta blockers, in which their cardiac output may get reduced, or ACE inhibitors because of kidney dysfunction, that's also a sign. And then once someone has chronic hypertension but has a drop off in their blood pressure, that may also be a sign for cardiac amyloidosis. And so these are the two different main types, AL and ATTR, and kind of the clinical clues that lead you one way or the other. And so one of the points, interesting things about ATTR amyloidosis is diagnosis is often delayed. And this basically shows different studies from international countries in which the time to clinical presentation to diagnosis is typically between 2 to 4 years. And so that becomes very important because we now have new therapies to treat cardiac amyloidosis. So it's important to keep a high degree of clinical suspicion. And so a lot of times the early and most common manifestations are non-cardiac. So carpal tunnel syndrome, ocular peripheral neuropathy, those are really common. And then later stage, then you'll start to see things like AV block, low voltage, LVH, and then cardiovascular manifestations as well as strokes and TIAs, and that can occur much later. And so this EKG shows typical low voltage, particularly in the limb leads. And this is an echocardiogram that shows diffuse LV wall thickening. There's also, the valves look slightly thickened and the RV is thickened as well with prominent trabeculations. You also have very large atria. And this is an example of a strain bullseye map on echo, and the pathognomonic imaging finding is apical sparing, or cherry red bullseye map. So that means that the apex has preserved or hyperdynamic function or increased strain, whereas the base tends to have severely reduced strain. And this is a nice review article that looks at imaging targets in cardiac amyloidosis. And it kind of illustrates the difference between true LV hypertrophy that can occur from either aortic stenosis or chronic hypertension, in which you actually have increased size of the cardiomyocytes, whereas people with cardiac amyloidosis, although they have increased wall thickening and LV mass, they actually don't have true hypertrophy because their cardiomyocytes are not increasing in size. Rather, they're getting displaced by these amyloid and fibril deposits, like in between the cardiomyocytes. And so this lists some of the amyloid tracers that you can use in nuclear scanning to detect. I would say the most common is PYP scan. And here you can see on CMR and echo, when you do cine imaging or just general echo wall motion evaluation, you see often increased wall thickness over 1.2 centimeters. CMR is really useful for detecting extracellular volume fraction, which can then be a gauge of the kind of burden of disease, more than just that the disease is there or not. So it's very useful. And so one of the ways to evaluate cardiac amyloidosis is to perform clinical kind of evaluation followed by echo and CMR. And basically one of the decision points is to determine whether is a plasma cell dyscrasia present. And so that's very important because it leads you down a separate pathway to kind of go the hematology oncology route, potentially get a bone marrow biopsy, do a limited workup, and then do immunohistochemistry staining for biopsy of either non-cardiac or cardiac tissue. Oftentimes, like most often, cardiac tissue will be preferred, or you can do mass spectrometry to confirm light chains and amyloid deposits. And then you can get diagnosed with AL amyloidosis. If you don't have a plasma cell dyscrasia, then you kind of go the route of the PYP scan, in which if you have strongly positive PYP scan, then you can ascertain whether there's a TTR mutation with genetic testing, and that will kind of divide the decision tree to determine if it's hereditary from a genetic mutation of TTR or wild type. So it could be either one. And then if the PYP scan is negative, then basically it's cardiac amyloidosis is unlikely, but you still should, if you still have a clinical suspicion, you should still proceed with biopsy depending on the level of suspicion, because that's the gold standard. And so this shows LGE in amyloidosis. And basically this is an example of early, intermediate, and late. And so it's different from cardiac sarcoidosis. So instead of having kind of little patchy involvement, when you have intermediate degree of cardiac amyloidosis, or if it's been going on a few years, a lot of times you'll get diffuse subendocardial enhancement, and it could also involve the RV. Here you could see kind of more basal predilection, but it does extend up to the mid wall. And then when it's very late in the disease course, it looks terrible. You could basically see LGE almost everywhere. It's transmural, it's patchy, it's like all over both the LV, RV, and the atria. Same with TTR. And so I was going to talk a little bit about what I was talking about earlier, inversion time and nulling. And I won't get deeply into the MR physics of it, but basically what you try to do when you're acquiring images to create especially for LGE, is you want to create the best degree of contrast between the myocardium and the blood pool. So what you want is the myocardium to be nulled, to be black, and for the blood pool to be bright. And so the way that works is you do 180 inversion pulse, and basically you give the heart and the blood a chance to recover. So in a normal person, the blood will hit 0. As you can see here, you'll see scar blood earlier than the myocardium. So basically you're trying to take advantage of this time delay, that when does the blood pool cross 0? When does the myocardium cross 0? So if you hit the place where you basically are trying to null the myocardium, so you kind of have to wait till there's a sweet spot of when the blood has recovered significantly, so it has an increased signal, but the myocardium is nulled. So that's what you're trying to do with a normal study. However, in amyloidosis, you have abnormal nulling of the myocardium. And the reason that is because of the fibrils that are interdigitated in the myocardium. They create significant disruption. And so instead of getting nulled after the blood, it gets nulled before the blood. So here you can see the blood is dark, which is not what we want. And then the myocardium is kind of grayish and there's lack of contrast. So once this technologist identifies this, then basically what they do is another set of sequences to determine the optimal T1 time that they'll then use for the LGE images. So it just requires another step. Like once you see this weird nulling, you basically then do a scan that looks at progressively increasing T1s. And then after you do that, you visualize the image, you see which one looks the best, which one is the myocardium black and the blood as light as they can get. And then you use that exact T1 to put into the future sequences looking at LGE. So it's kind of a complicated technique, but if a technologist is very savvy, they'll be able to do this. And so here's just more examples of suboptimal nulling that you can see in cardiac amyloidosis. And so some of the pathognomonic findings include high myocardial gadolinium uptake, interstitial expansion, which results in increased in extracellular volume fraction. And then you could see global subendocardial uptake or transmural. You sometimes see shortening of subendocardial T1 and then rapid blood pool washout, which basically makes it look like it's not nulled. And so there's also a utility of non-contrast T1, which they call native T1 or T2. And that's typically performed a lot of times when the GFR is less than 30. And so that's relatively common in patients with cardiac amyloidosis since it's multi-system disorder. And it's particularly high with amyloidosis, so native T1 values. If you see intermediate values for institution, it's kind of non-specific interstitial expansion. And then T1, T2 mapping is also helpful because you can visualize and quantify active inflammation and edema. And some of the patterns of abnormalities may suggest a specific etiology. And so this is a nice chart that shows kind of a gradation of cardiac amyloid. So you start out with normal ECV, no LGE at all. And then usually the first thing to become abnormal is extracellular volume fraction, which you can determine with pre and post contrast mapping with no LGE. Later on in the disease state, then the ECV will be even higher and you'll start to see subendocardial late gadolinium enhancement. And then when it's very advanced in the disease state, you'll see markedly elevated ECV as well as transmural LGE. So that combination is particularly bad. This just shows prognostic value, particularly for T2. So that's been studied recently. So basically what this study found is that if the T2, so anything elevated, usually above in the 40s is abnormal. Here they found a cutoff of 55 milliseconds. So those who had elevated T2, which is indicative of edema, had reduced event-free survival in AL amyloidosis compared to those who had T2 less than 55 milliseconds. And just to put some of these mapping techniques in context and kind of reiterate what I stated earlier. So this is a native pre-contrast T1 map showing the diseases that cause low T1, as well as the diseases that cause elevated T1. And amyloid is one of the ones that cause the highest T1, myocarditis. You can see smaller elevations in HCM. And then extracellular volume from pre and post contrast T1, you start out with normal. And then using this kind of color scale, once you start to get to the green, light blue, at least according to this scale, you have more evidence of increased burden of amyloid. So that's something very important, like a key take-home message of this is the higher the ECV, the higher the burden of cardiac amyloid. And this chart shows kind of what the T1, T2, and ECV shows you. And so basically it's kind of reiterating on the microscopic level what I just previously showed. But when you have edema of the myocardium, like post-MI or cardiac sarcoidosis, you'll usually get elevations in everything. So T1, T2, ECV. If you have scar tissue, you'll get elevations as well in all three, but you'll also get LGE, so that helps to clue you in. And then if you have lipid or iron accumulation, that's one thing that causes reduction in T1. And it shouldn't affect T2 or ECV unless something else is going on. And so these are just more examples, kind of getting used to seeing native T1 maps, extracellular volume maps, and the color scales could be different from place to place. But basically, here's an example of a native T1 map, and you can see the technologist usually will circle a region of interest or a couple, so you can see what it is in the septum. And if basically you're dealing with a diffuse process like cardiac amyloidosis, you should be able to capture what the kind of average T1 value is in either the septum or a couple areas of interest, and they get averaged. Here's another example of a native T1 map as well. And then here's LGE showing kind of diffuse subendocardial LGE, and then an extracellular volume map. Basically showing values here, I think it's 39% and 62, so it's very elevated, and then a perfusion map at the end. And so this is just another example just from a different paper showing just cardiac amyloidosis, kind of using echo and CMR. So here's just an example of basically similar to the patient I showed you before. So increased LV thickness, RV thickness, AV valve thickness, pericardial effusion, restrictive pattern on Doppler, basically for diastology, and then the cherry red pattern on the strain map. And then similarly with CMR, oftentimes you'll have abnormal function, wall thickening, elevated T1, T2, ECV, and then in this patient, like just a lot of edema and fibrosis. And so it's important to know some of the red flag signs for ATTR because this is very common. And so some of the red flag signs, particularly on imaging, are the apical sparing sign on echo strain imaging, or if you see a discrepancy between the LV wall thickness and QRS voltage on EKG, like I just mentioned. If you start to see heart block, echo hypertrophic phenotypes with thickening of the AV valves, that's as well as the RV free wall. And then on CMR, some of the red flags are marked extracellular volume expansion, so a very high ECV. Or if you see abnormal nulling time for the myocardium, like I showed you earlier, or a diffuse LGE that's transmural. Those are all really red flag signs, and I'm sure require further workup and aggressive management. And the general principles for cardiac amyloidosis treatment depend on the identification of the precursor protein, so kind of going down those two pathways, AL or ATTR, and generally involve diuretics, sodium restriction, like any heart failure patient. But what's really important is also surveillance and treatment of atrial ventricular arrhythmias, monitoring over time of conduction disease, kind of similar to cardiac sarcoidosis, and then general avoidance of negative inotropic or chronotropic drugs, which they oftentimes in advanced cardiac amyloidosis can't handle well because they're very reliant on the stroke volume, and then avoidance of vasodilator therapy. So now I'm going to transition for the last 10 minutes into ARVC, which not an infiltrative heart disease, but is a very important genetic cardiomyopathy, which you should all be aware of. And to start, I wanted to talk about the nomenclature because that's become actually a source of debate. So you'll sometimes see ARVC called ARVC, and that's kind of more common in the United States. And basically, it was kind of like the guidelines for the nomenclature that were developed in the United States, mostly the Heart Rhythm Society, they kind of endorse that terminology. However, there's a whole movement in Europe in which ARVC is referred to as ACM, or arrhythmogenic cardiomyopathy. And the main difference is that in the United States, ARVC is a very specific diagnosis of this hereditary myocardial disease that primarily affects the RV, but can also affect the LV. They, in the HRS, the Heart Rhythm Society, they call ACM as more of an umbrella term of kind of non-ischemic cardiomyopathies that can cause arrhythmias. So they consider like cardiac sarcoidosis an ACM, and ARVC is just one type of ACM. So that's how it's regarded in the United States. Whereas in Europe, there's basically been a movement to replace the term of ARVC with ACM. So when someone says ACM, oftentimes they consider that equivalent to ARVC. So just so you know, you might see in the literature, depending on which paper you read and which kind of society you follow, whether it's referred to as an ACM or ARVC. And so they're not really interchangeable, just is my point. But it's a relatively rare disease, and it's genetic, characterized by myocyte loss that's accompanied by fibrofatty replacement. And it happens that Hopkins is one of the centers of excellence in the country, so we actually see a lot of ARVC patients. The prevalence is relatively rare. It's 1 in 5,000. And similar to the other diseases, infiltrative heart diseases I mentioned, it predisposes you to arrhythmias, heart failure, and sudden cardiac death. And one study showed that the presenting symptom of sudden cardiac death is basically the first presentation in about 11% of patients. And so that's pretty catastrophic. That's a relatively high number. And so just one slide about kind of the pathology behind ARVC is you really have desmosomal disruption. So the connections between the cardiomyocytes are disrupted from a genetic cause. However, the genetic cause is unknown in about 1/3 of patients. And it's really thought that mechanical stress that can occur through vigorous exercise can actually promote the pathologic changes in ARVC. And it's thought that mechanical stress can lead to disruption of the desmosome, and instead of healing the way that normal people do, basically the heart gets taken over by this fibrofatty infiltration of the RV primarily. And that can lead to reentrant VT. And so the diagnostic criteria, the original ones were developed in 2010. They're kind of modified more recently, but basically they include, and this is from the Heart Rhythm Society, basically include a variety of imaging, clinical, and other diagnostic criteria. And they basically consider definite ARVC as having 2 major of these criteria, or you can have 2 minor, and 1 major, or you can have 4 minor from different categories. And so in terms of echo, I'll get into that in a second, but there's certain criteria that are based primarily on RVOT measurements, as well as RV fractional area change. Whereas on MRI, there's more emphasis on RV ejection fraction and RV volumetric. So what's the RV end diastolic volume? And then do you see regional RV akinesia or dyskinesia? Or RV ejection fraction less than 40%. Other things you may see are tissue characterization showing abnormalities of the RV free wall. You can also see repolarization abnormalities on EKG. So that's another diagnostic criteria. If you have like more inverted T waves other than V1 to V3, you can also see depolarization conduction abnormalities, ventricular arrhythmias, and then family history is very important too. So those all make up the diagnostic criteria. And then I just wanted to show you on echo how we do our measurements and how they relate to the ARVC criteria of the HRS. And basically, we do 2 important measurements on the parasternal long axis as well as the short axis. And so the measurement that we're most interested in is RVOT proximal. And so that's measured at end diastole, and it's an inner to inner measurement, basically vertically at this junction right here. And then on the short axis, that's also a vertical measurement right above the aortic valve, and it's inner to inner. And so you can see the cutoffs that they use here, index to body surface area. So if it's for the parasternal long axis, it's 3.2 and up is a major criteria. If it's a short axis, it's 3.6 and up. And then the other thing we look at is RVFAC, which basically is calculated, it stands for RV fractional area change, and it's calculated from the area of the RV in the forechamber at end diastole compared to the RV in the forechamber at end systole. So basically the sonographer should get those 2 measurements, and then you can calculate RVFAC. We also oftentimes do strain, although because it's a newer technique, it's not in the guidelines. So in terms of looking at strain of the RV, most literature says you should mostly focus on the free wall because you have the option of including 6 segments. Like you can include 3 of the septum and 3 of the free wall. But for the most part, we go by free wall measurements because the septal measurements are kind of considered merged with the LV. So there could be pathology in the LV that's affecting it. So we mainly go by RV free wall strain and kind of average those 3 segments. And so the terms of CMR, like everyone with ARVC will get a CMR, and it's very useful. In terms of the particular sequences that we use that are kind of catered to ARVC and what we're looking for in terms of RV pathology. So we'll do the traditional Cine, SSFP, 2-chamber, 4-chamber short axis stack, which is very standard, but we'll also do a specific RVOT view. And I'll show an example of that. In addition, we'll do tissue characterization. We'll also do late gadolinium enhancement at the same planes of the Cine imaging. And so this shows you an RVOT view, basically showing diastole and systole. And you can see an area of dyskinesia at the inferior wall. So here's diastole, and in systole, it's kind of bulging outward, and then akinesis of the RV free wall. This also shows a common finding that is much easier to see on CMR than echo, but at microaneurysms of the free wall. You can sometimes see them on echo if they're very obvious, but because of the limitations of echo, those could easily be missed because they're very small. And this is an example of someone who has a very dilated RV that you can see both on the Cine short axis as well as the 4-chamber. And then this is, we don't often get CTs, but sometimes they're not part of the traditional diagnostic pathway, but sometimes we get CTs for, especially with people with ICDs for follow-up. And this is a pre-ablation CT. And here you can see ICD with the artifact, and you can nicely see microaneurysms in the RV free wall. This also shows evidence in ARVCs. A lot of times you'll see RV inferior wall or anterior wall late gadolinium enhancement. So you can see these bright areas in the RV inferior wall. And then oftentimes what's been increasingly recognized is LV involvement in the ARVC. So sometimes you'll get a codominant pattern, and there's certain genetic defects that predispose people to codominant or left dominant. And here there's no particular sort of pathognomonic LGE finding for the left side in ARVC, but here's a focal area of abnormal late gadolinium enhancement in the inferior and lateral wall. And then this is another example of LV involvement in a CMR using LGE. And so you can see here in this, basically this 4-chamber view, that there's LGE in the subepicardial area. And they call that the reverse angle of dysplasia because there's a very significant area in the RV. So it's just kind of a catchy term that's used in the LV. And this is an example of RV feature tracking with strain, which sometimes is used for ARVC. I don't think it's completely available at all places, but it's used a lot for research, and it could be useful because it enables you to detect more subtle forms of RV dysfunction, which have prognostic value in ARVC. So basically what technologists will do will just acquire basic Cine images, and then using post-processing software, you can acquire RV strain similar to an echo. And so at the end of the day, you'll obtain RV free wall longitudinal strain with feature tracking. And it's also important to determine the normal values of a given institution. And so some of the challenges in diagnosis of ARVC include poor specificity of EKG findings, particularly early on, multiple possible causes of ventricular arrhythmias, as well as generalized difficulty assessing the RV. So a lot of times we'll get inadequate echo images. We're not doing 3D imaging routinely, and then we'll get much better CMR images. So those are useful clinically. And at times there could be inconclusiveness, or sometimes you won't ever get a genetic diagnosis in about a third of patients. And in terms of prognostic value, I'm sorry this got cut off, but some of the useful markers on echo are TAPC and RVS primed. So they're reduced in ARVC as well as predict events in ARVC. And then one final thing I wanted to mention is just keep in mind overlap diagnoses, because ARVC can often be confused with athlete's heart, other pathologies such as sarcoidosis or myocarditis, or just idiopathic dilated cardiomyopathy. And so some of the clues you can find on imaging. So athlete's heart is hard, but basically if someone does have athlete's heart, usually the wall thickness is less than 15 millimeters. And then there's an absence of regional wall motion abnormalities. And then sometimes if it's really unclear, like if it's an athlete that maybe has ARVC, sometimes they'll detrain to see if the LV thickness recedes after stopping exercise for a while. Sarcoidosis has more characteristic non-ischemic LGE patterns. And then because cardiac sarcoidosis is more of a multi-system disease, you'll often see other clues like mediastinal lymphadenopathy or abnormalities in FDG PET. In terms of myocarditis, that's usually a little more obvious because you'll see more evidence of tissue edema and reduced LV function. And then dilated cardiomyopathy is so nonspecific, but it primarily involves the LV, although the RV can be involved at later stages. So that's the end of my talk. And I know I went through a lot today, but I hope at least you can remember some of the pearls of using CMR in these 3 diagnoses. And I'd be happy to answer any questions. Yeah, and feel free to speak up.
Thank you, Dr. Hayes, for an exhaustive lecture. That was really very comprehensive. We have one question. Can you differentiate between viral lymphatic myocarditis pattern versus sarcoidosis on cardiac MRI?
Oh, that's a great question. I think it's very challenging. I think a lot of times cardiac sarcoidosis is initially diagnosed as just non-specific viral myocarditis. So I personally find that very challenging. So my husband's actually an expert in cardiac sarcoidosis, and he leads a center at Washington Hospital Center, and he finds that one of the most challenging things is to dissect that apart. And sometimes there'll be overlap, and a lot of times it has to do with the clinical picture too. Myocarditis, as you know, like it takes a really long time for the troponins to decrease, and you may still have residual inflammation, and kind of has it more like a mid-myocardial enhancement a lot of times, although that's not always the case. And then sarcoidosis is generally patchier, and I feel like maybe PET scan, especially if they're extra cardiac features, might be able to help tell apart those two. But I think it's very difficult clinically, and that's a great question.
I think that was just Alice. That was just amazing, Alison. Thank you very much. Very comprehensive, informative, and an excellent lecture. So clearly you see a lot of sarcoidosis, a lot of amyloidosis at your place. So what is your usual workflow when you get a patient? And the question is, evaluate for amyloid. Do you start with the cardiac MRI usually and then go from there, or in terms of imaging? I mean, after the blood.
In terms of imaging, first echo, and then I'll always start with a CMR. Part of it has to do with how easy it is to get, but I feel like it'll kind of lead you down a certain pathway, because I feel like the CMR could help you distinguish, especially if they're both on the differential, cardiac sarcoidosis or amyloidosis. And then we'll start using like the kind of biomarker workup for light chain. We'll do that in everybody with suspected amyloidosis. But I feel like the CMR helps as a decision tree, whether someone should then go on for PYP scan if the if there's no plasma cell dyscrasia, or if they should go on for a PET scan. And so, one thing I've noticed is sometimes the CMR is completely negative for cardiac sarcoidosis, but you still have suspicion, and those patients should still get a PET scan, because sometimes you'll see abnormalities on PET, but with absolutely nothing on CMR.
Absolutely. And in your usual protocol, you do mapping for all the patients you're suspecting for both sarcoidosis and amyloidosis, or?
Yes, we're using, it was fairly recent, but we're doing mapping routinely now. I think it's a nice tool. I think that when it becomes unclear of its value is for things like COVID myocarditis, like you'll sometimes see like tiny abnormalities of uncertain significance, and there's like a large debate about what to do with those. But one thing I recognize is if you have co-localization of abnormalities, like if you see abnormal T1 and then you see a focal area of edema on edema imaging, like T2 stir, and that correlates with an LG, then it seems like it may be more real rather than sort of like an isolated abnormality of uncertain significance. But yeah, right now we're doing routine T1, T2 mapping for cardiomyopathies.
Awesome. And if you have somebody you've diagnosed as amyloidosis based on your scans in your clinic, who is starting treatment, like the tafamidis on these patients? Is that you guys, or are you sending them to HEMONC?
No, we're starting that in cardiology. If there's I guess a reason to involve HEMONC, like if you're suspecting like plasma cell dyscrasia, will involve them. But for starting those, we send them to amyloid. We have like a specialized center here. It's kind of small now, but I think it's an area that they're looking to build. And they also notice that a lot of times patients initially diagnosed with HFpEF will have it. So they do have an area of expertise where cardiologists are familiar with that drug. It's also very hard to get and expensive, but basically we'll send it to that center, the amyloidosis center.
Awesome. Awesome. Deepak, you want to?
Dr. Hayes, we have like two more questions. So one is, I wonder regarding non-compaction, is there a LGE pattern for this cardiomyopathy? Is it possible to have positive T2 stir within the non-compacted myocardium?
Well, that's a really interesting question. I haven't seen that. I haven't seen edema of the non-compacted myocardium, but we don't see it very often here. It's fairly rare, but we do mapping. I guess I personally haven't seen isolated elevations in edema in the non-compacted, but I'm sure it's happened. I'm just not as familiar, but that's a really good question. I'll have to look it up to see if there are case reports.
Sure. And then
I think it would be very hard to look for edema in the non-compacted myocardium if you're, because there's so much of blood pool over there. So probably not the ideal. But as far as the LGA pattern for non-compaction goes, usually we see a little bit of fibrosis sometimes in the non-compacted portion, but not very often in our experience. I don't know how you feel, Alison.
Yeah, I don't see it very often at all. I've seen it a couple of times, but it seems very non-specific in its distribution.
And the next one is in cardiac amyloid. Can you have any unremarkable MR, but positive PYP scan? Probably negative cardiac MR, positive PYP scan.
In cardiac amyloidosis, that's a really great question. I feel like I've seen negative LGE, but positive PYP, but oftentimes if you're going to get extracellular volume, that will often be abnormal. I feel like that's very characteristic of cardiac amyloidosis. So I haven't seen where it's completely negative, even the ECV, and then I've never seen that, but I have, I guess I've seen where the LGE is negative, but they'll go on to have a positive PYP. That's a great question though. It's really interesting. And thank you for the invitation. It was a pleasure to give this talk to everybody.
Yeah, thank you very much. Really appreciate your contribution and all the information you have provided. And thank you also for sparing your Saturday morning to spend an hour with us. So
my pleasure.
Very kind of you. Thank you. And thank you all to the audience who again have decided to spend this beautiful Saturday morning with us. Appreciate your coming over. We will resume again next week, same time, Saturday morning at 9 a.m. So look forward to seeing you again. Have a wonderful week. And again, thank you to Deepak and Vikram for being part of this and working with me. Thanks.
Thank you for organizing this. I thought it was terrific. So we appreciate it.
Thank you, Alison. And again, we also have lectures on echo that we did last year. We did echo lectures on general cardiology and intervention the year before. So they're all uploaded on our website. Along with this will be uploaded in the next few days on the website. Granted, Saturday morning, people have commitments and whatever else, but they also get posted on our YouTube channel for the Iowa ACC, and we have thousands of views sometimes, or close to hundreds at least. So I think these lectures are very informative for people who are kind of trained in cardiac MRI, from what I'm seeing from the mixture of audience, but also people who are really fellows with minimal experience. I think it's really adding to their fund of knowledge. So thank you very much for doing this. I mean, it would not be possible without speakers like you. Absolutely. So
thank you, Dr. Hayes, and thank you everybody who has tuned in today. So yeah, I mean, all the resources are available on the Iowa ACC website. I have shared the link as well, and we'll keep sharing the link on every Saturday. So this should be uploaded in the next couple of days. So yeah, and thank you, Dr. Ashford, for the opportunity.
thank you. Bye-bye.
All right.
Thank you, everyone.
So we tune out and have the rest of a good Saturday morning, or wherever you are from part of the world. Thank you. Bye-bye.